Hello, hello, hello.
Yes, ma'am. Good morning. Ma'am, we are live on the platform, ma'am.
Hello, is somebody there?
Ma'am, you are audible.
Neeraj?
Yes, ma'am.
Good morning, friends. I'm Professor Sheila Mayatra, working at the Department of Anesthesia, Critical Care and Pain at the Tata Memorial Hospital. I will be your chairperson for this session. We have a very interesting session lined up today with expert international faculty. The session is on hemodynamic assessment and monitoring. I would like to introduce the first speaker of the session and the first topic. Professor Thomas Sherin is going to be speaking on predicting hypotension in the perioperative and critical care medicine. Professor Sherin is a professor of anesthesiology at the University Medical Center in Groningen in Netherlands, and his area of interest are hemodynamic monitoring, goal-directed therapy, tissue oxidation, and the microcirculation. And he's also the editor-in-chief of the Journal of Clinical Monitoring and Computing. And he's going to be speaking on a very interesting topic. So over to you, Professor Thomas Sherin, to speak on predicting hypotension in the perioperative period.
Looked at between 2010 and 2016, and there was Hello, my name is Thomas Sherin from the University Medical Center in Groningen in the Netherlands. And I would like to discuss with you the prediction of hypotension in the perioperative and particularly the critical care setting. These are hopefully my conflict of interest related to this talk. Okay, so if we look at hypotension, we are interested in the outcomes, and the outcomes that we are particularly interested in are the cerebral outcomes, the renal outcomes, and the heart outcomes, and of course, mortality. So let's focus on these outcomes. So this is a study published 2 years ago. Almost 9,000 patients with sepsis from 110 hospitals in the US were looked at between 2010 and 2016. And there was search for the incidence of hypotension longing for more than 2 hours and less than 4 hours. So between 2 and 4 hours hypotension under different thresholds. And the results were that under the threshold of 65, which is a widely accepted mean arterial pressure threshold, there were 62% of patients having a lower blood pressure than this. Below a threshold of 60, it was 37% of the patients, and below a threshold of 55, almost every fifth patient, so 18%, had a lower blood pressure than 55. This is a smaller study in 111 patients with septic shock. And again, they looked at the time that mean arterial pressure was below certain thresholds. And you can see here that in the non-survivors from these patients, they spent more time below different blood pressure thresholds than the patients who finally survived. And the mean arterial pressure was an independently associated with mortality, as you can see here. This is another study in patients with sepsis, which looked at the association between the mean arterial pressure below 60 during the first 24 hours and 28 days mortality. And you can see here that the longer the blood pressure was, the more hours the blood pressure was below this 60 millimeters of mercury threshold, the higher was the mortality. And this is a recent study published also 2 years ago, more than 5,000 patients with distributive shock. Most patients had at least one episode with a mean arterial pressure below 65, lasting more than 2 hours during their ICU stays. And again, the episodes of prolonged hypotension under different thresholds were associated with higher mortality, as you can see in this graph. This group from the Cleveland Clinic looked at the association between the time-weighted average of mean arterial pressure below 65 for in-hospital mortality, and in-hospital mortality increased by 11% for every unit that this time-weighted average increased. So a very clear association. The same association was found for acute kidney injury here on the left, and also, although to a lesser extent, for myocardial injury. So the higher the time-weighted average of mean arterial pressure below 65, the higher the incidence of these adverse outcomes. So this is another study from the Cleveland Clinic in almost 3,000 patients, post-operative patients admitted to the surgical ICU, and they wanted to determine the relationship between hypotension and a composite outcome of myocardial injury and death. They looked at 405 patients, and they also wanted to look at the acute kidney injury in the ICU. 15% of these patients, 405 out of 2,800 had acute kidney injury, and there was a strong association between the lowest mean arterial pressure and acute kidney injury. And these, for the hazard ratio for acute kidney injury was 1.27 per 10 millimeter increase, so a 27% increase per 10 millimeter decrease in the lowest mean arterial pressure on each day during the ICU stay. And this is from the same study, the results between mean arterial pressure and myocardial injury or mortality. And you can see here again a clear association. For example, if the patients were below the 5th percentile, this is 67 millimeters of mercury, they had a 67% increased risk of mortality or myocardial injury. So the conclusion from this study, even brief periods of hypotension, as defined by the lowest mean arterial pressure per day, were strongly associated with acute kidney injury and with a composite of myocardial injury and mortality within the initial 7 postoperative critical care days. So this population of postoperative surgical patients seems to be particularly sensitive to even mild amounts of hypotension. And the question arises, what is the real threshold of myocardial injury, kidney injury, or even mortality? Is it 65 or is it even higher? And you can see here that even at the 85 threshold, mean arterial pressure of 85, there was a significant increased odds ratio for all of these adverse outcomes, and the lower the mean arterial pressure threshold, the higher the incidence of any of these outcomes was. So maybe even higher values are associated with organ injury. All right, this is a study also from the Cleveland Clinic looking at postoperative delirium, or again in post-surgical patients within the first 5 postoperative days. And you can see here that the lowest mean arterial pressure or any mean arterial pressure below 75 were significantly predictive for postoperative delirium in the postoperative period. And this is a study in patients after resuscitation from cardiac arrest, so a different population. And again, you can see here the higher the mean arterial pressure was, and we're talking about really high levels here, above 110, the better was the odds for a good neurological outcome. And these were the odds ratios showing that mean arterial pressure greater than 90 was significantly improving the outcomes of these patients. So if we want to summarize up to this point, the definition of hypotension is variable, but the mean arterial pressure below 65 appears to where the harm starts to occur. Hypotension, not only intraoperative, but also in the ICU, defined at this threshold, is very common and is associated with poor outcomes, myocardial injury, renal injury, stroke, delirium, and even mortality. The lower the mean arterial pressure and the longer the duration of the hypotension, the higher was the risk of harm. So reducing the hypotensive burden may improve the outcomes. And this brings us to the prediction of hypotension. Well, how does this work? When the clinical signs of hypotension occur, this is this point, this is not the reason, the origin of the hypotension. This is further down in the past. And this is only the point where all the compensatory mechanisms fail, so the hypotension becomes clinically evident. But the reason for the hypotension lies in the past. And it would be nice to detect this point in time early to be able to find the hypotension at an early stage. The problem is that the current monitoring that we have, even advanced monitoring, is excellent at telling us if the patient is stable right now at this moment, but it's not good at detecting instability early or to predict the near future of that patient. And this is where the hypotension prediction index comes into play. How does it work? We can look at the arterial waveform, and if we exaggerate one beat from this arterial waveform, we can see so in this full cardiac cycle, there's a lot of information, like information on the contractility in this part, the upstroke part of the curve, the stroke volume, the arterial compliance, the afterload, and the vascular tone. All of those are seen in this curve. They cannot be seen visually by the human eye, but they will be detected by the computers, if you look at it. And this brings us into the artificial intelligence, machine learning, where we need big data for that to come up with predictive algorithms, as you see here. So the hypotension prediction index, which was developed by engineers from Edwards Life Sciences, has been published 2 years ago. This is the study published in anesthesiology. And how does it work? It works exactly as I told you. So they look at the arterial pressure waveform, they divide it into 5 parts. And by combining these different features from the arterial pressure waveform, they end up with a combination of more than 2.6 million combinations, which they fed into this into their machine learning model, and to come up with a final prediction model, which they call the hypotension prediction index. And what is that? It's just a number between 0 and 100, a dimensionless number. A low number means that the probability of developing hypotension is low, and a high number means that the probability is very high. Of course, they validated their algorithm, and this is the study. So they looked at patients from the ICU, but also patients from the OR, and they looked at patients from the public MIMIC database. And they also had an external validation where they validated their algorithm, which they had been developed here. And these are the results from the internal validation. So this is the performance of the hypotension prediction index 5 minutes, 10 minutes, and 15 minutes before hypotension actually occurs. And you can see that the area under this curve is quite good. So the predictive ability is excellent. These are the results from the external validation, the red lines, also very good, as you can see here. And this is a case that they published in that paper. This is an intraoperative case, a patient undergoing major abdominal surgery. He has a mean arterial pressure around 85. At this point, the pressure drops to about 75, but still way above this 65 threshold, which I put here with red dots. But at this point, the HPI goes up and is warning us that hypotension will occur. But actually, it took another 17 minutes before the blood pressure actually dropped below the 65. So these 17 minutes could have been used to think about the reason behind the hypotension and to think about a therapy for this hypotension. We also had a look at this hypotension prediction index and did an external validation of that in 255 surgical high-risk patients, all of them receiving goal-directed fluid therapy. And you can see here that the higher the hypotension prediction index was, as I said, it's a number between 0 and 100. The higher was the actual event rate, being hypotension, and the shorter was the time to that intervention, to that event, to that hypotension. Now you might say, like this colleague, I can predict hypotension by just looking at mean arterial pressure or the changes in mean arterial pressure. And maybe you're right. So if we look at this screenshot, this is a trend of mean arterial pressure going down, and then you can easily extrapolate this line until the 65 to predict hypotension, right? So you might say, I don't need this fancy number of HPI telling us that the hypotension will occur. So the question is HPI actually a mirror of mean arterial pressure? Yes or no? If it would only be a mirror, then it would be of little added value. So we looked at this particularly question. So we compared the performance of the HPI against the changes in mean arterial pressure, as you can see here. So the solid lines are the performance of the HPI. This is 0 minutes at the moment of hypotension. So the prediction was perfect at this point, of course. And this is 5, 10, and 15 minutes before the hypotensive events. So again, as in the validation study from the Edwards people, the predictive ability was very good also in our study. And now let's look at the changes in mean arterial pressure. Can they also predict hypotension? No, they cannot. This is a mean arterial pressure change at this point of hypotension. So even then it was less able to predict hypotension than the HPI. And this is 5, 10, or 15 minutes before the hypotensive events. And you can see this is just like flipping the coin. So no predictive ability at all. And we also looked at any other hemodynamic variable that you might think of, like cardiac output or stroke volume or pulse pressure or heart rate or stroke volume variation or shock index. None of these were as good as the hypotension prediction index in predicting the hypotensive event. These were the values for 5 minutes before the hypotensive events, but the values 10 minutes and 15 minutes look pretty much the same. They are in the paper if you are interested. So how could this change our management? And this is what we wrote down here as an idea. So the current treatment is a reactive treatment. So we wait until the hypotension occurs, until the blood pressure falls below 65. Then we give a therapy, maybe at this point, and then we can reverse the blood pressure. But with this reactive treatment, the hypotension does occur. With a new hypotension prediction index, which tells us early that this hypotension will occur, we might consider giving this treatment earlier, so before the blood pressure drops, and this way prevent the hypotension from occurring. So this is the idea. Does it work? This is a study from Germany in almost 100 patients undergoing hip surgery, and actually this, compared to the control group, they could reduce the incidence of hypotension by 50% in this group. So yes, it works. They could also show that they could reduce the number of hypotensive events from 5 to 0 per hour, the duration from 11 to 0 minutes, and if you relate this to the case time, from 6% of the case time that the patient was hypotensive to 0% of the case time. So quite impressive data, and we brought an editorial to this, saying this is a very important first step, and it may allow reducing the incidence of the duration of intraoperative hypertension to almost 0, and also what I just told you, from a reactive treatment of hypertension to a proactive blood pressure treatment. This is another study, the HYPE study, performed in Amsterdam. Again, they had 2 groups of patients which were randomized to an early warning system, which is nothing else than the HPI, and a standard group which had a normal flow track sensor. And by using these HPI, they could reduce the time-weighted average of hypotension dramatically and significantly to almost 0 again. So there was a significant reduction of hypertension by using the HPI. There's also a negative study, if you will, this one from the Cleveland Clinic, 200 patients having non-cardiac surgery. They were again randomized to treatment with or without the HPI. The primary outcome was the amount of hypotension about below different thresholds, and they could not find a difference. So HPI was not able to reduce hypertension in their study. However, if you look at this paper, they said that half of the hypertension HPI alerts were not followed by any treatment, presumably because it was too short, or the algorithm that they used was too complex, or the clinicians were simply ignoring the alert. But how can you expect a reduction in hypertension if you do not act on the alarms? Anyway, this is another study using a different algorithm, which is not commercially available as far as I know. And they tested it in 1,100 patients from the MIMIC database and some own patients. And again, they could show that in critically ill patients, the algorithm trained on multiparametric data was able to identify acute hypertensive events up to 30 minutes in advance. So this is another way of detecting hypertension. If we treat hypertension, can we avoid hypertension by treatment? Yes, we can. And does this have an impact on the outcome? This is a study suggesting this, a study published in JAMA 3 years ago, 300 patients randomized to 2 groups. In the one group, the blood pressure, the systolic blood pressure was maintained within 10% of baseline values, awake baseline values. And in the control group, the blood pressure was only treated when the systolic pressure fell below 80 or more than 40% from baseline. The primary outcome was organ dysfunction, and this primary outcome was significantly less, 38% versus 52% in the standard group. The risk was 14%. So actually, by avoiding hypertension, you could reduce the risk of organ damage, not totally to 0, but at least to a significant amount, suggesting that there's not only an association between hypertension and bad outcome, but maybe a causal relation. So if we want to treat hypertension, of course, we have to consider what is the reason behind the hypertension. This could be hypovolemia, so a decrease in cardiac preload. It could be a decrease in systemic vascular resistance, vasoplegia, or it could be an impairment of myocardial contractility. And the secondary screen, which we call it, which comes along with the hypertension prediction index, and automatically comes up when the HPI value is alarming, it gives you an information or an indication about the reason behind the hypotension, which could be a problem with the preload. In this case, you might consider giving volume to that patient. It looks at the contractility, and if this is a problem, you might consider giving an inotrope, or it looks at the afterload, the dynamic elastance, or SVR, and in this case, you should give a vasopressor. Briefly summarizing how it works, so the dynamic variables you are all aware of, they are based on heart-lung interaction. You have the pulse pressure variation calculated like this, or the stroke volume variation, which tell you if a patient is fluid responsive, meaning if you increase the volume of that patient or give him volume, that he will increase his cardiac output or stroke volume. And this is how it works. This is the Frank-Starling curve. And if a patient has a high stroke volume variation or pulse pressure variation, he will probably increase his stroke volume when you increase the preload by a volume load. If the patient, however, is on this part of the curve, the same increase in volume will not increase stroke volume that much. So this is a non-responder. The second variable that comes with the secondary screen is the estimation of the cardiac contractility, the DPDT. This is the upstroke of the arterial pressure waveform, the maximum change in pressure over time. And if the heart is contracting very well, this increase will be very steep. If the heart, however, is pumping very slowly, this increase will be less so. And this also correlates with the left atrial pressure waveform if you measure it on the peripheral artery. So this DPDT can be used to aid clinicians in the use of inotropes to treat hypotension. You have to check the baseline values for this, not targeting a specific value. And it has probably the highest impact in terms of change of practice because inotropes were not previously used for treating hypotension that much. And the third variable finally is the dynamic arterial elastance. What is this? This is nothing less than the ratio of pulse pressure variation and stroke volume variation. It predicts the pressure response in preload responders. I can show you this on this line. So this is a pressure volume curve of a patient. Imagine the stroke volume variation is 15, so the patient is volume responsive, but the pulse pressure variation is only 10%. Dividing 10 by 15 gives a low value below 1. So this patient will probably not increase his blood pressure if we give him volume. If the patient, however, is on this part of the pressure volume curve and has the same stroke volume variation of 15, but now a pulse pressure variation of 25, then 25 divided by 15 is a number greater than 1. So this patient will probably increase his blood pressure along with cardiac output if you give him volume. So the clinical questions that the dynamic elastance might have answering: if the patient is fluid responsive, otherwise it does not work. Will arterial pressure improve with volume administration? The considerations are: if the dynamic elastance is high and the patient is preload dependent, then arterial pressure will improve along with cardiac output after volume expansion. And the greater the dynamic elastance, the greater the improvement in arterial pressure will be after that volume expansion. So I like to call it the stroke volume variation of the pressure world. And this is to summarize how I would proceed with this algorithm. So if the patient is hypotensive, look at the stroke volume variation if he is in a preload dependent state. If that's the case, you give him fluid. This will certainly increase the stroke volume. And if you want to know if it also will increase the blood pressure, then you have to look at the dynamic elastance. So my take-home messages for you is there is no safe mean arterial pressure or no definition for hypotension in the ICU. Hypotension, mostly defined as a mean arterial pressure below 65, is, however, associated with poor outcomes, renal injury, myocardial injury, delirium, mortality in the ICU setting. hypertension can reliably be protected in 2021. And this may change our practice from a reactive treatment, so waiting until the blood pressure drops, to a proactive blood pressure management, so giving the treatment before the blood pressure even drops, and from an unspecific treatment, like giving a vasopressor to every patient, to a more causal blood pressure management because your patient might need an inotrope or volume. The secondary screen variables help finding us which is the appropriate treatment by looking at the reason for the hypotension. But of course, we need further studies to show that if we do this, that this will improve the outcome of our patients. With that, I thank you very much for your attention.
Thank you very much, Professor Sharon, for that excellent presentation and telling us about how to predict hypotension in the perioperative period. I would like to take the session forward and now introduce the second speaker. We have a very interesting lineup of talks. I request you to put your questions for Professor Sharon in the Q&A session. Our next speaker is Professor Xavier Monet. He's a Deputy Chief of the Medical Intensive Care at the Paris-Saclay University Hospital. His areas of interest are circulatory failure, fluid therapy, catecholamines, hemodynamic monitoring, heart-lung interactions, and echocardiography, essentially everything to do with cardiovascular dynamics. And as I mentioned, he's affiliated to the Paris-Saclay University Hospital. He's also the chair of the cardiovascular dynamics section of the ESICM. He's associate editor of the journal Annals of Intensive Care. He's on the editorial board of the journal Critical Care, and he's also on the scientific committee of the International Symposium of Intensive Care and Emergency Medicine, which is held at Brussels every year. Now, he's going to speak to us on a very interesting topic, using tissue oxygenation to individualize the mean arterial pressure in critically ill patients. Is this the best way forward? Over to you, Professor Xavier Monet.
So let's speak about the individualization of mean arterial pressure, and I first disclose that I collaborate with Pulsion Medical Systems and with Lactate. So tissue oxygenation to individualize mean arterial pressure. Let's put that question in its context. In patients with acute circulatory failure, we may use fluids, vasopressors, and inotropes, in addition, of course, to treating the etiology, the cause of shock, and in addition with organ supports, of course. But these treatments have in fact different targets. Fluids and inotropes are aimed at increasing cardiac output, which may change oxygen delivery and which may change oxygen consumption. And with vasopressors, of course, we expect an increase in arterial pressure, not cardiac output, which may change organ function. In this lecture, we will focus on arterial pressure and more specifically on mean arterial pressure. Why? Because mean arterial pressure is a very meaningful variable. Let's go back to physiology and to the relationship between organ perfusion flow and organ perfusion pressure. For all organs except the left ventricle, the organ perfusion pressure is the mean arterial pressure. And the relationship is this one. When mean arterial pressure decreases, the flow initially remains constant because of microvascular dilation. But below a critical pressure, flow decreases and organ function impairs. So mean arterial pressure is a very meaningful hemodynamic variable. This is illustrated by many studies. For instance, this one in septic patients, and hypertension was quantified in length, but also in depth. And the authors showed that hypertension was an independent marker of prognosis in this patient. At multivariate analysis, I mean, it was an independent factor from all other severity markers. So it is a meaningful target for vasopressive therapy. So it means it's something that might be used to target the dose of vasopressors. Nevertheless, the level of MAP we should target is unclear in many cases. Why? You remember the results of the well-known sepsis PAM study. Septic shock patients were randomized between two levels of MAP, 65-70 or 80-85, and survival was similar whatever the level of MAP which was targeted. But subgroup analysis revealed that patients with previous hypertension had a better renal function if the highest value of MAP was targeting during the study period, with less doubling of creatinine levels, with less renal replacement therapy. But the price to pay was more atrial fibrillation. And this better renal function with high MAP levels in previous hypertensive patients is explained by pathophysiology, because the relationship we have seen before is shifted rightward in case of chronic hypertension. This results in a higher critical pressure. So the MAP target should be adapted to the presence or absence of hypertension. Nevertheless, which target should you try to reach? The level of pressure which should be targeted in case of previous hypertension might be different from one patient to another. Should it be 80, 85, 90? It may depend from one patient to another. It's not only the patient that may determine this target, it's also some other factors, as for instance, CVP, the central venous pressure. Because let's bear in mind that the organ perfusion depends on the perfusion gradient between the MAP and CVP. It's not MAP only, CVP matters. And this study well illustrated the importance of CVP. The risk of persistent acute kidney injury depending on the CVP level. The higher the CVP, the higher the risk of persistent AKI. So it means that actually choosing a MAP target in a given patient is not that easy. We need some variables to individualize the target of MAP in a given patient. Which variables may we use? It could be variables reflecting the organ function, or for instance, variables reflecting the sympathetic tone indirectly. For instance, skin vasomotor tone variables. Urine output should be particularly interesting because we have seen that the renal function is directly related to the MAP level. It's very easy to measure, nevertheless, it is unhelpful in a large majority of patients because these patients are simply anuric. And also the changes in the urine output are of course delayed compared to the change in the dose of pressors. So unfortunately, urine output is not very useful in practice. So this might be the interest of the variables reflecting the sympathetic stimulation and the skin vasomotor tone, capillary refill time, and skin mottling. As you know, the interest in capillary refill time, CRT, has raised with the publication of the Andromeda shock study. Septic patients were randomized, guided by lactate, and resuscitation guided by peripheral perfusion and CRT. And the cumulative mortality was similar between groups. Nevertheless, in the most severe patients, in the subgroup of the most severe patients, those with the highest surface score, survival was significantly better with the CRT-guided resuscitation. And also, the CRT-guided protocol led to an improvement in the surface score significantly over time. So does it mean that we should replace some complex targets by skin perfusion targets to guide resuscitation, to guide, for instance, the dose of pressors? I'm not sure, because what are we speaking about? The CRT, capillary refill time, is for sure a meaningful variable. This is, for instance, illustrated in this small size study in septic patients. CRT was different between survivors and non-survivors, and the CRT value was able to prognosticate mortality of the patient. So it makes sense. But is it really useful? No, because the measurement of CRT might be complex in many cases. This is illustrated by this study. In this study, CRT was used to assess cardiac output changes during a passive leg raising test. So it might be something interesting if you do not measure cardiac output with a specific monitoring device. Nevertheless, look, CRT was in fact the average of 4 values. And the least significant changes, the smallest changes in CRT that might be trusted, were not less than 25%. This is not precise enough. And even more, CRT was measured with a smartphone camera, with a controlled light, and to be reproducible, they standardized the CRT measurement by applying a pressure with a syringe piston at a constant volume, and they analyzed CRT using a specific software, etc. And they recognized that the method to assess CRT was time-consuming and might be unrealistic in routine clinical practice. So CRT perhaps, but it is not that easy to measure. And it's not very precise. Perhaps skin mottling, because again, it makes sense. In this study, quite large study, again, the mottling score, a way to quantify mottling, increased when mortality increased. But again, it's not very useful in clinical practice. In this study, mottling was present in only half of the patients. And of course, it's useless in patients with dark skin. And even more, it's likely not very precise. So, of course, these skin vasomotor tone variables might be useful, but not in all cases, should not be neglected, but they likely should not be used alone. Nevertheless, the question that is asked in the title of the lecture is tissue oxygenation to individualize MAP. In fact, tissue oxygenation variables reflect the adequacy between oxygen consumption and oxygen delivery. But oxygen delivery is not determined by the mean arterial pressure physiologically, but by cardiac output. So it's important because it means that if you use the tissue oxygenation variables as targets for adjusting MAP, bear in mind that this is only because MAP indirectly reflects cardiac output. And the first of these tissue oxygenation variables is, of course, SpO2, the oxygen saturation of the venous blood. Why? Because we know the well-known relationship between oxygen delivery and oxygen consumption. And it reads from the right to the left. When oxygen delivery, for instance, during cardiogenic shock, initially, oxygen consumption remains normal and tissue function normally. And this is only due to the increase in oxygen extraction, of course, which is reflected by the decrease in SpO2. SpO2 is a very meaningful variable because it accurately reflects the adequation between oxygen consumption and oxygen delivery. Nevertheless, there are two drawbacks of SpO2. The first is that in many cases, it is unhelpful because it is normal in spite of tissue hypoxia. And of course, this is the case in septic patients because of the impairment of oxygen extraction. In this cohort of septic patients, you see that as CVO2 was normal, was higher than 70% in 70% of septic patients. So it's a large proportion of patients where we cannot use SVO2. In such cases, by the way, we may use lactate instead of SVO2 to detect a tissue hypoxia. This is very important, by the way, to explain the results of the RIVER study and of the studies that attempted to confirm the RIVER study. You remember that SVO2 was the target that was used to guide treatment in the RIVER study. Then, since SVO2 was normal in the majority of the patients in the studies that attempted to confirm this RIVER study, it is not surprising that these studies were negative. It was not the case in the RIVER study itself, because it included some very specific patients with low SVO2 values. And the other drawback of SVO2 is that, bear in mind, its true value is accessible only through the PA catheter. And many old studies showed that this estimation of the mixed SVO2 by the central SVO2 is not that good. So perhaps we might be interested in lactate. Again, it is a very meaningful variable because it increases as soon as tissue hypoxia appears. It reflects prognosis, and keep in mind that prognosis starts to be impaired and mortality starts to increase for very small increases in lactate values. As soon as lactate increases by more than 2 millimoles per liter, mortality starts to increase. There are almost no false negatives to detect tissue hypoxia, and it's easily accessible. Two drawbacks. The first is that, as you know, there are many false positives, cases where you can detect tissue hypoxia with SVO2. It's not either lactate or SVO2. Both might be interpreted together. And this is why I'm always very surprised. I was always very surprised by these studies trying to show that it was better to use SVO2 or lactate to guide therapy, with some studies that showing that lactate was better or that SVO2 was better. In fact, we don't need to choose. Both are cheap, are easy to sample, are easy to interpret, and they are independently useful. Let's take the example of patient with cirrhosis, so a cause for false positives of lactate. Lactate is elevated. What will tell you that tissue hypoxia appears is as CVO2. And let's take the example of patient with septic shock. As VO2 is normal, or as CVO2 is normal, it might be due to oxygen extraction impairment. So lactate will tell you, for instance, that the patient improves when lactate decreases. The other drawback of lactate is that it takes time to change and to decrease, for instance, when the patient improves, when oxygen consumption improves. In this study, for instance, with shock patients, mainly septic shock patients, we measured SVO2 before and after fluid infusion in patients where oxygen extraction, oxygen consumption improved with fluid administration. And you see that SVO2, which was normal at baseline, because of oxygen extraction impairment, remained normal in these patients. Lactate was able to detect the improvement in oxygen consumption, but it took time to decrease. Nevertheless, a variable that decreased immediately with fluid administration was this ratio between the PCO2 gap and the arteriovenous difference in oxygen content. What are we speaking about? About the PCO2 derived indices of tissue oxygenation. If you think about the basic physiology of CO2, it is obvious that CO2, the PCO2 gap, the veno-arterial difference in CO2, has two determinants. The first one is cardiac output, which carries CO2 from the tissues to the lungs. And so if cardiac output decreases, the PCO2 gap increases. And the other determinant of the PCO2 gap is cell metabolism, because aerobic metabolism produces CO2. When you consume O2, you produce CO2 according to the respiratory quotient. How might the PCO2 gap be helpful to detect anaerobic metabolism? In fact, in case of anaerobic metabolism, two factors modify the PCO2 gradient in opposite directions. On the one side, anaerobic metabolism produces acids that will be buffered, which will produce CO2, which will tend to increase the PCO2 gap. Nevertheless, at the same time, since less oxygen is consumed, less CO2 is produced, which tends, conversely, to decrease the PCO2 gradient. And so to perfectly detect an anaerobic origin of CO2, we should rather index the PCO2 gradient by the oxygen consumption. And if the ratio between VCO2 and VO2 increases, we know that anaerobic metabolism occurs. So the next question is, how could we assess that ratio at the bedside? If you develop the FEB formula and if you simplify by cardiac output, you come, and if you estimate that the CO2 content is the same as the CO2 pressure, which is true in normal condition values, you come to this ratio between the PCO2 gap and the difference in oxygen content. It's a marker of anaerobic metabolism, and its response is, in theory at least, faster than with lactate. How is it helpful? In this old study by Armand de Sappe and Jean-Louis Deboul, they showed that the high value of this ratio was able to detect high values of lactate. And in this study, we showed, again with Jean-Louis Deboul, of course, we showed that the decrease in this ratio occurred as soon as oxygen consumption improved with fluid administration. And so this ratio might be actually useful in cases where lactate is increased, which might be due to some false positives, for instance. So these PCO2 derived indices are accurate, rapidly detect changes in oxygen metabolism. It's slightly better to measure them with a mixed venous blot than with a central venous blot, and they are unfortunately less validated than lactate and SpO2. So to summarize, which target should we monitor to adapt the treatment, and especially pressors? Not one variable, but all of them together. Thank you very much for your attention.
Thank you very much, Professor Monet. That was a very interesting presentation. And now we move on to the next speaker. Our next speaker is another expert on hemodynamic monitoring. And he's going to be talking to us on a very interesting topic. He's going to talk about hemodynamic incoherence in critically ill patients. So I welcome Professor Janin Che. And Professor Janin Che is the head of the Translation and Intensive Care Medicine Department of Intensive Care at the Erasmus Hospital in Rotterdam. And he's the professor of clinical physiology, cardiovascular aspects of perioperative and intensive care medicine. He's previously also been head of Department of Translation Physiology at the Academic Medical Center of the University of Amsterdam. He's past president of the Dutch Physiological Society, former chairman of the Scientific Committee of the Netherlands Society of Intensive Care Medicine, and he's also been the past president of the International Society of Oxygen Transport to Tissue. Professor Janenche is an expert on the microcirculation, and this will be a very interesting talk, hemodynamic incoherence in the critically ill patients. Over to you, Professor Janenche.
Good afternoon, ladies and gentlemen. My name is John Inge, and I have the honor to give you today a lecture on the microcirculation in the critically ill patient. I work in Rotterdam in the Netherlands in the Department of Intensive Care, where I head a laboratory of translational intensive care, which I hope you will take the opportunity to visit one day. Unfortunately, I'm not in India, which I really would have loved to have been due to the present situation everywhere, and hopefully I will be able to see you in vivo in the future. I have some declared interests which I would like to share with you, and that is that I have a company together with Matthias Hilti. We've developed a lot of the methods and the software I will be talking about today, and you can access it on Active Medical BV if you're interested in collaboration with us. So the most important thing to realize really is that I'm a physiologist. I'm interested in how things work or how things don't work, and to try to understand the underlying mechanisms. And over the years, we've really tried to understand what is going on in shock. Because shock is a state of the circulation which is unable to deliver sufficient oxygen to meet the demands of the tissues, resulting in cellular dysfunction. So it is a cellular definition, shock, not just hypotension. Of course, we use in the clinic different parameters relating to this situation, such as hypotension, lactate, etc. But ultimately, we would like to be able to monitor directly what's going on in this vicinity of the cells. And if we look at all the best review papers on these subjects, it always is that fluid therapy, for example, its purpose is to improve microvascular blood flow. And by doing that, increase the cardiac output. So microvascular blood flow is an important endpoint which has to be reached. However, in the clinic, there are very little conditions in which this is actually being measured. And if we look at the microcirculation, which is the ultimate destination of the cardiovascular system, we see really that that is the place where the primary end goal of all hemodynamic action is taking place, because that is the place where blood has to go to, oxygen-rich blood, and deliver it to the tissue cells in the area to meet their metabolic demands in support of organ function. And that is why mean arterial pressure and all these other things are important, but they're dependent parameters. Ultimately, it is oxygen-carrying red blood cells in the microcirculation. And the microcirculation is not just a single concept. It's a very complex collective of cellular systems, such as the red blood cells, for example, leukocytes, endothelial barrier, mitochondria, and all of these together act in unison to ultimately achieve the aim of the cardiovascular system, which is to provide the microcirculation with oxygen-rich red blood cells. So it's an integrative compartment and very dependent and very different from organ to organ. So many years ago, end of the last century, we introduced OPS imaging into the clinics, and we were the first to were able to actually directly observe the microcirculation, first in surgery and later on in critical care medicine. And here, for example, the first studies that we did were in during neurosurgery, showing the brain tumors and subarachnoid hemorrhages, etc. And what we actually see in these images are dark black and white pictures, and the dark pictures are actually red blood cells. They are, and the technique makes use of green light, which is absorbed by these hemoglobin in the red blood cells. So we're basically seeing as functional or dysfunctional red blood cell filled capillaries. And here you can see indeed that in the subarachnoid hemorrhage, this granular structure is actually the hemorrhaged red blood cells spilling over into the subarachnoid space. In critical care medicine, measuring under the tongue has proved to be the most successful measuring site. And here we can see emanating from the external carotid artery, the lingual artery feeding the sublingual capillary bed, and that is a very easily accessible place, and some 600 papers have been now produced using this technique. So OPS imaging was later followed up by SDF imaging, and the most recent one is so-called IDF imaging. And we can see with great detail the red blood cells. Here you can see single red blood cells, again, measuring it underneath the tongue. The big challenge in this whole field has been really the quantification and understanding what the functional parameters are of the microcirculation measured sublingually. So over the years, there's become increasing interest in this particular field. And in 2018, we wrote in Intensive Care Medicine a consensus paper of a large number of opinion leaders, key opinion leaders in hemodynamic monitoring. Here you see us all together in Brussels, and we published this paper in which all the various technical, physiological, and clinical aspects of sublingual microcirculation measurement was discussed. And this is what a normal sublingual microcirculation looks like. One can see here, for example, larger vessels going into even larger vessels. These are venules going from 2 to 1. And here we can see smaller capillaries in which there are single cells, one by one, and these can then also flow into the venules. And if one looks carefully, we can see here the white blood cells as white globules going through a venular bed. In sepsis, we see a very disturbed microcirculation in which there are areas completely not filled by red blood cells. Once more, we can only see vessels in which there are red blood cells. These are either plugged or are moving erratically, and this is a typical image of a septic patient. Giving fluids to such patients doesn't really improve the situation itself, and what one sees instead is there's still areas which are plugged next to areas going very, very fast. And this is really the image which is characteristic of distributive shock, in which the distribution of the microcirculation is the prime hemodynamic alteration, as opposed to what is going out of the heart or the cardiac output itself. Here we see disseminated intravascular coagulation, in which we see this large area completely plugged up. And once again, you can see the various heterogeneous nature of the malfunctioning of the microcirculation in this particular patient. This is an example of a patient who had undergone cardiogenic shock and had received epinephrine, in which the cardiac output was restored, mean arterial pressure was normal, but as you can see, at the expense of tissue perfusion. So this became more and more apparent in the field that even though you might normalize the systemic parameters, the microcirculation might still be in shock. And this led really to the concept of microcirculatory shock, in which despite changes in systemic parameters, such as the cardiac output, very, very little response was seen in the microcirculation, emphasizing the need for microcirculation-guided therapeutic agents to be administered. So here's an example exactly of what we were talking about this discrepancy between the systemic and the microcirculation in the study done by Alex Lima and Bülent Ergin. Here we see a pig, a cardiac output at baseline of 4 liters, mean arterial pressure normal, lactate a bit high, and a renal blood flow of 364 milliliters per minute. This animal was given shock and then resuscitated with fluids to bring back the mean arterial pressure and the cardiac output back to baseline. And we can see here too that the SpO2 normalized and the heart rate a bit higher, but not excessively so. The lactate, however, was disturbingly high, and the renal blood flow had gone down to 68 milliliters per minute. Now, renal blood flow can't be measured at the bedside. So the only thing that we can really see about this is abnormal lactate. And look at what the kidney looks like in this particular situation, almost necrotic. So what other parameter which we could have measured in this animal would have indicated that there is some hemodynamic failure really resulting in this, this completely sick kidney being? Well, this was the microcirculation measured sublingually prior to the whole LPS endotoxin infusion, and this was after the resuscitation. And as you can see, there are areas here again that are plugged next to areas in which there is flow, this characteristic heterogeneous composition. So we have referred to this condition in which there is a disassociation between the systemic circulation, the microcirculation, as a loss of hemodynamic coherence. Because hemodynamic coherence is the condition when the systemic hemodynamic variables are in parallel to movements in the microcirculation. It's the expectation of correcting cardiac output or any other systemic parameters is that if you do that, that the microcirculation tissue perfusion improves in parallel. But if there's a loss of hemodynamic coherence, that is the so-called unresponsive patient. And the only way of really identifying that is to measure sublingually. And here's an example done by Jacques Touranteau in Paris, which exactly shows this condition in patients, traumatic hemorrhagic shock patients, entering the trauma unit and immediately being resuscitated. And as you can see here, their heart rate, mean arterial pressure, cardiac index being normalized. However, despite this initial normalization within hours, taking up to 4 days for the microcirculation to be normalized. And the length for which it was taken was related to the SOFA score. So the longer it took to normalize, the worse the SOFA scores was. So hemodynamic coherence is a condition where correction of the systemic hemodynamic results in a parallel improvement in the microcirculation. And here we've identified 4 types which are associated with this one, allowing us to do a microcirculatory triage, if you will, to identify what the cause is of shock. There is the heterogeneity, in which there is a abnormal flow of the microcirculation in between the different vessels. And here we see hemodilution, in which the oxygen carrying capacity, and the third one in which excessive vasopressor therapy has been used, resulting in a tamponade in the microcirculation, and the fourth type, tissue edema, in which the diffusion distance between the capillaries and the cells are very large. So I will only discuss with you the distributive microcirculatory shock and this characteristic of sepsis. And this type of microcirculation is indeed associated with mortality in septic shock patients, and has been shown in many, many studies, this particular one from Buenos Aires, and also from the studies from Daniel de Backer and Jean-Louis Vincent, and showing that this is really, this characteristic type of microcirculation is associated with adverse outcome and is the most sensitive and specific parameter showing that. Here we can see such a situation. You can very easily see why you've got a reduced oxygen extraction if this is what the microcirculation looks like, because the oxygen is simply shunting the cells, resulting in high venous saturation in the presence of high lactate. And this is the model, the shunting model of sepsis, which we described in the late 90s in critical care medicine as explaining what is going on in distributive shock during resuscitated sepsis. So looking back again at the physiology of this thing, we basically have 2 important components in the microcirculation. We have the convection, which is really the flow part, and the diffusion, which is the ease and the distance between the red blood cells and the tissue cells. So in resuscitation, really everything is focused on increasing flow, and there is nothing which is regarding to diffusion. However, both components are the rate-limiting components for oxygen transport to the tissues. So in heart failure, you have a normal diffusion and low convection, and in hemodilution, you have a large diffusion distance, but a normal convection, large diffusion distance due to the dilution of the red blood cells by the resuscitation fluids. So in this way, we can look at the convective and the diffusive components of the different types of shock, in which, for example, anemic shock requires a resuscitation based on diffusion, whereas cardiogenic, hypovolemic, and obstructive shock more so on a convective, and the septic shock a combination of the 2. Now, all of this has been relatively difficult to analyze, etc., until our recent development of automatic software to analyze these at the bedside, done by Matthias Hilty. First was a mathematical description in communications biology, Nature publication, and later on we did a clinical validation, multicentral, multinational clinical validation study. And this allowed us really using data mining to identify the diffusive and the convective components of different types of disease states, but also different types of resuscitation strategy. So here we saw, for example, that sepsis has got diffusion and convection and low cardiac output, a different combination of the two. And here we can see that anesthesia, which causes vasodilation, is much more a diffusion component, whereas a assist device, such as an LVAT, is much more sensitive to the convection part of the resuscitation. So here we can see how these methodologies can be used in a goal-directed, methodology-based, mechanistic-based approach to giving an effective resuscitation. So the last part of my talk really has to go about then thinking about, well, what could be an ultimate parameter which we could use? Everyone talks about tissue perfusion. So we've thought about this particular concept in great detail. What does it mean, tissue perfusion? Does it mean the flow? Does it mean the velocity, number of red blood cells? Well, it is clear that at the bedside, it is often used, such as capillary refill time. But what it exactly is that you are measuring in terms of regional microcirculatory blood flow is not well defined. Actually, because red blood cells are the predominant carrier of oxygen to the cells, it must be related to that. So fluid resuscitation in itself then becomes a questionable way to achieve this because it relies on the dilution of red blood cells. So this brings us to the realm of the capillary and the capillary hematocrit, what it means, and because that is ultimately the oxygen-carrying component, and the discharge hematocrit. We developed methodologies to measure this sublingually, and we have produced this paper last year in which we identified what we think is the ultimate parameter, which is the target parameter in resuscitation medicine, which we have named tissue red blood cell perfusion, which is the perfusion of capillaries by red blood cells per unit time. In the paper, it is explained what it exactly is based on sublingual microcirculation. And here we can see, for example, that if we apply these concepts to fluid therapy, that if you have too little of fluids, hypovolemia, you have a convection limitation. And if you give too much fluids, you start getting a diffusion limitation. And the ultimate optimal fluid will be in between these two, in which you've got a maximum number of red blood cells, convection at a normal method. So here's the example of our pig again. And what we've done now is give hemodilution to the pig. And as you can see, the more you hemodilute the animal, the faster the red blood cells goes. So you would say, well, that the tissue perfusion is improving. But if you look at the velocity, it indeed goes faster. But if you look at the tissue red blood cell perfusion, it actually goes lower because the density of red blood cells starts to decrease. So the last slide I'd like to share with you is the recent study we did just online in critical care medicine, and how we apply these concepts and also other concepts which I've not had the time to talk about, like leukocytes and microaggregates, to COVID patients. And this COVID patients showed a completely different type of a reaction in the microcirculation, nothing looking like sepsis, no plugged vessels, rather an increase in the systemic hematocrit, in the capillary hematocrit, in which we could see that there were a lot of red blood cells in the capillaries at the expense of the systemic hematocrit. So it seemed that the response to COVID, to hypoxemia of the body, was to take away the red blood cells from the systemic circulation and to focus on providing oxygen to the tissues. Much the same, actually, as happens at high altitude, except in these patients, there were a lot of leukocytes and microaggregates. The interesting thing was that this adaptive response to hypoxemia was only prevalent in patients who had SOFA scores less than 10. If a patient had a higher SOFA score than 10, this adaptive response was not present. So this again shows how useful such a microtools analysis can be in giving us a completely mechanistic insight into a completely unexplained, from a pathophysiological point of view, new disease such as COVID-19. So ultimately, we of course first have to measure the macrocirculation and to make sure that it has been resuscitated. But after that, ensure that the microcirculation in a hemodynamic coherence form has equally been resuscitated. If not, we have to look at new microcirculatory guided resuscitation methodologies. Thank you very much, ladies and gentlemen, for your attention, and I hope you have a wonderful conference, even though it is online. Thank you very much, and goodbye.
Otto, please play the CV and then video.
Hello, my name is Daniel Bakker, and it's my pleasure to discuss with you the assessment of left ventricular contractility by echocardiography. And we will discuss that it's not just the ejection fraction that we have to focus on. So we need to discuss what about the assessment of left ventricular systolic function. And of course, for this, the ideal index should be obtained on one single cardiac cycle. It should be reproducible, meaning that between different patients, the same value of the index should be reproducible, and also for among investigators, it should also be something very reproducible. We should have an index that is sensitive to small changes in contractility, and it should have limited sensitivity to loading conditions in heart rate. And we'll see that this is really not feasible with most indices, and that we will have to be satisfied by some indices that indeed at the end are not ideal, but can be used as a bedside relatively reliably. What about ejection fraction in itself? So the ejection fraction is a ratio between the ejected volume and the telediastolic volume. So it's a difference between the end diastolic volume and the end systolic volume divided by the end diastolic volume. So this can be measured by different ways. Differences in volumes, but remember that echo is two-dimensional, so we will need some artifice to try to measure or estimate the volumes. It's differences in surfaces and differences in diameters. This shortening fraction is, of course, done by many cardiologists. The advantage is that it is very easy to measure. It's just in time modes that we measure the level of the papillary muscle, the dimension of the ventricle, and it is easily computed by many softwares. Well, it is very simple, very rapid, but it has many, many disadvantages, especially because regional abnormalities may interact there. And of course, we can overestimate the function if the angle of the beam is oblique. So obviously, it is really not a very good one, but often you find it in the charts of the patient. So it's good to reproduce it just to know where you stand compared to what was measured a few months or years before. Surface shortening is really one of the most performed values. And so we look at the end diastolic area, the end systolic area, and we do the ratios there. And this is, of course, obtained in the parasternal short axis. And the problem is, of course, again, to be at the level of the papillary muscle. And so the angle of the beam will be, of course, very important. We need really to measure it at the insertion of the papillary muscles because the contractility is not exactly identical at the level of papillary muscles, at the apex, or at the level of bases. And the level of the papillary muscle is really integrative of the entire function in most patients. So again, it is simple, rapid. The problem is, again, the regional abnormalities, the angle of the beam, and of course, alterations in the left ventricular shape that make it a little bit more complicated to estimate the shortening fraction. And you can see here that here with this patient with Takotsubo, we have here at the level of the papillary muscle a very good ejection fraction, but globally the function is not good because we have apical lack of contractile function, so that at the end, the ejection fraction is much lower than what was measured just looking at the shortening fraction at this level here. So we should look perhaps at volumetric measurements. And for this is really what is now recommended by many societies. We need indeed to try to measure the surfaces in two perpendicular axes, so that at the end, we try to estimate really the volumes by measuring in 4 cavities and 2 cavities and measuring it by the Simpson method. And so we go first on the apex here, we do the apical 4, then the apical 2, and we indeed do the Simpson method there. So why the Simpson method? Because it is a summation of all these small discs that at the end will cover the entire surface here. This is how it was done here in this patient. And you can see that even though the apical, the apex was not contracting as well as the other parts, we can really measure here the systolic volume, the diastolic volume, and we can compute here the ejection fraction without any problem. So it is really valid even when we have regional wall motion abnormalities, and this is really very crucial. It is nevertheless a little bit cumbersome, and we need, of course, to have a very accurate visualization of the borders and of the apex. Is it reliable? Probably yes. If we look here at the correlation with the angiographic ejection fraction, we have a very good correlation here. And the problem is that the confidence interval is quite broad because indeed we can see here for a Simpson measured around 45%. Of course, the average value is of 45%, but we can have some patients here with a true value of 55 or a true value of 35. So it's not exactly identical, honestly. So should it be really measured or can we estimate it by eyeballing? We can see that indeed categorization into normal, moderately depressed, or severely depressed function can indeed be easily done at the bedside. And in most cases, this is still quite enough in most cases. And of course, we need to discuss all the advantages and disadvantages here. And if we look at all the factors, the most important one, it is that it is load dependent. And in this context, it is really something important. Also, mitral regurgitation by unloading the ventricle may overestimate the true contractile function of our patients. And this is really something important. And again, the it can be done automatically, so the human factor can be somewhat minimized, and this is, of course, quite good. And also we can try to do it in true 3D echo, so this can perhaps improve a little bit the fact that we just use 2 axes to try to have the volumes drawn by the surfaces. But at the end, is it really accurate? Probably yes, but we still have some caveats in the measurement. So we still need to be very cautious that it is not a true measurement of the angiographic ejection fraction. Nevertheless, it's quite a good estimate of it. We can, of course, use also the contrast enhanced ultrasound to try to improve it. And indeed, with this, we can even have much better and more reliable measurements, but of course, it's a little bit more cumbersome and, okay, quite expensive to perform. But again, you can see here, very accurate measurement compared to the true ejection fraction by angiographic techniques. So the most important aspect is really, what does it really represent? Why is it useful or not to measure the ejection fraction? And so we know that ejection fraction is dependent on afterload. And it's also dependent on preload. And we have also, at the end, some interdependency between systolic and diastolic function, because when we have diastolic impairment, the heart cannot really fill, and so we have a decrease in diastolic volume, and hence a decrease in ejection fraction for a given contractile function. So at the end, is not a very good estimation of the contractile force, because we have so much interference with all these factors. So should we true it? Well, no, it is very good measurement, because what it does is that it reflects the instantaneous equilibrium of the cardiovascular system with the intrinsic contractile function, the preload, and the afterload. So it is a kind of ventricular arterial coupling that we are looking at. So it's not really contractility that we are assessing, but the way the heart is coping with the loading conditions with its intrinsic contractility. And it is perhaps much better at the bedside than the pure contractile function. But we will discuss later on how to try to better assess the contractility itself. Cardiac output is also a way to assess the contractility. But of course, what we do is to measure the aortic VTI, so the flow passing through the left ventricular flow tract, and we can indeed measure the cardiac output by this way. And this is a good way to really have a very precise measurement of the cardiac output. And so we can have a very good correlation between the ultrasound cardiac output and the thermodilution cardiac output over a broad range of cardiac output measurements. Well, is it reliable? Well, we have this kind of papers in literature, and we can see that indeed it's not always that good. But if we look at the details, when we look at the measurements performed using the aortic VTI, then indeed, in most instances, we can see that the percentage error is quite acceptable in these conditions. And it's really in very old-fashioned way to measure cardiac output that indeed the percentage error is much broader. So probably it's quite reliable in using the left ventricular flow tract measurements. And again, recently it was shown to be really reliable with a percentage error of 25% only. So we still have some problems because, of course, we measure the left ventricular flow tract, and so a small error is elevated to the square. And you can see just by 1 millimeter error, we have a half a liter error here in these conditions. And so we probably, in most cases, use always the same left ventricular flow tract value, or we just use the VTI. We nevertheless need to pay attention to the angle of the beam, because here again, we can make some significant errors in the measurements. But nevertheless, it's quite a good measurement. But it is a measurement of the total flow, which is a cardiovascular performance. And so it's much broader than just the contractile function, of course, in these conditions. To try to assess more precisely the contractility, we can look at the rise in the left ventricular pressure, or the DPDT max, which is very close to a physiologic measurement of the DPDT. And so what we do, we have to look at some regurgitation of the mitral flow, and then we look at the acceleration here between 1 meter per second and 3 meters per second. This represents a 32 millimeter of mercury difference, and then we look at the time spent to go from A to B, and then of course we have the normal values of around 1,000 millimeters per second. And again, here it's done here, and you can see that it's very easily done at the bedside indeed. It is independent of afterload because it investigates only the early phase of ejection. The problem, is it dependent on prelude or independent of it? Well, you can see here that it is truly independent of afterload because indeed there is absolutely no change here in the context of the pure vasoconstrictor administration. However, it is markedly dependent on preload. You can see here, vena cava occlusion, we have decrease in the pressure of the left ventricle, but you can see that DPDT also decreases with decrease in preload. So unfortunately, DPDT is dependent on the preload itself also. So it is good in this, but still preload dependent. So we can also look at the longitudinal contraction. Why can we look at the longitudinal contraction? Because the longitudinal contraction accounts for 10% of the ejection of the ventricle. But in most cases, the longitudinal contraction is proportional to the global contraction. So by just measuring that aspect, we can estimate the global contraction of our patients. And so we can do it by looking at the S-wave, the MAPC, or the global longitudinal strain, 3 different techniques. So basically what we do is to look with the MAPC and the S-wave, just 2 techniques different. The S-wave is measured by tissue Doppler imaging, and the MAPC is just the M mode. But what we are looking is the displacement of the mitral annulus during systole and diastole. And so by looking at the displacement of the mitral annulus during the systole, we can indeed have this evaluation of the longitudinal contractility. And here again, we can see during tissue Doppler imaging here at the medial part of the annulus, and we can see here the movement here, anterior movement of the mitral annulus. And so here we have indeed the normal value, which should be above 9 centimeters per second. Small measurements, so risk of errors. We can also do another one, which is the MAPC, so the M mode, putting it again at the medial place or the lateral place during the mean of it. And you can see again the movement here of the mitral annulus during the systole, again, medial and lateral, and we do, of course, the mean of the 2. And this is quite a very sensitive one, and you can see that in septic shock, we have difference between survivors that have a slightly higher but improve over time, while non-survivors fail to improve it over time, and that indeed it can separate survivors and non-survivors very adequately. Also, interestingly, the MAPC can be used to separate the patient who will tolerate or not the administration of beta blockers in sepsis. You see here, patient who will increase the stroke volume or patient who will decrease the stroke volume when beta blockers will be given to try to counteract the tachycardia. And there was no obvious difference in most of the hemodynamic indices, including the dose of norepinephrine and so on and so on. But the MAPC was really very important because the MAPC above 1.3 was associated with preservation of the cardiac output in stroke volume, while the MAPC below that value was associated with a decline in stroke volume when the esmolol was given in this patient with septic shock. So it's quite good in this to evaluate the contractile function at bedside. And then we can also, of course, use this strain or spectral tracking. You can see here that we can look here at the regional strain and the global longitudinal strain here, minus 11 here percent, which is indeed looking at the total movement of the anterior movement of the left ventricle. How do we estimate this global movement? Well, if we look at the myocardium, there are some small parts, more echogenic or less echogenic, that the device can really detect, and the device will track the changes and movements of all these particles, and so look at the movement from the old location to the new location over time. And so indeed, we can look at the displacement here, and we will be particularly interested in looking the longitudinal displacement of these parts of the myocardium. And we can look, of course, at different segments to try to see whether one segment is better performing than another segment. And so what is most interesting for us is a strain more than strain rate, which is the current length minus the original length divided by the original length. And so that's why it is in percentage. And of course, because it is moving away from the probe, it will be negative. And so we are mostly looking at the global longitudinal strain with echo here. And so there are some advantages, of course, some disadvantages, but in experimental studies, it can really very nicely demonstrate some alterations that were missed by looking at classical indices here. We can also see that we can look at the movement of different segments, and sometimes some segments are less kinetic than others, and even sometimes dyskinetic, do not move in the same direction at the same time as the other segments. And interestingly, looking at the global longitudinal strain, we can see that a patient with sepsis have an impairment in their global longitudinal strain that is missed by the ejection fraction. And when we look at the prognostic value of the different indices here in septic shock, we can see that in septic shock, ejection fraction is not really prognosticated, do not prognosticate the outcome of these patients. However, if we look at the global longitudinal strain, we can see that indeed there is some difference here, and that the more negative global longitudinal strain is associated with a better outcome compared to a less negative global longitudinal strain. So survivors have a better strain than non-survivors, while the ejection fraction is relatively identical. Finally, when we think at the strain, it can detect early alterations in contractility, even when initially the heart is still able to cope with this impaired ejection contractility, so that the ejection fraction is maintained. Here we have some patients in septic shock. And we can see that initially we have patients who will never have some hypokinesia of their left ventricle, patient who immediately had some impairment in ejection fraction, and patient who have here some preservation of the ejection fraction, but impaired contractility. Because indeed, if you look at the strain, you can see that the strain is normal in the green patients, so normal contractile function, while it is depressed in patient in red with a decreased ejection fraction, you expect it. But also interestingly here, in these 7 patients here, the strain was altered, even though the ejection fraction was preserved. And later on in their evolution, these patients developed later some impairment in their contractile function, depressed at that time by decreased ejection fraction. So it is interesting to realize the strain can be performed initially to detect alterations in contractile function that initially are somewhat not representing some alteration in hemodynamics, but later on will be detected by some more severe alterations in the hemodynamics of these patients. So the contractility is best reflected by the DPDT, the mitral regurgitation, of course, the MAP-C, the S-wave TDI, and the strain here, global longitudinal strain. These are the best to reflect the contractile function of the heart. But how do we integrate all these factors? Contractility, ejection fraction, catechol. Well, it's relatively easy. We have the left ventricular contractility that together with preload and afterload will determine the ejection fraction. And so again, it is somewhat the ventricular atrial coupling, which represents the way, again, the left ventricle adapts to its loading conditions with its own contractility. So the two are important to measure. Then, of course, we have to look at cardiac output, because then we have the preload, afterload, but also the diastolic function, the heart rate, all together mix and lump into the cardiac output. And this is the cardiovascular performance globally. And at the end, it also reflects what matters for the tissues. The tissues do not care about contractility. They care about the blood flow that is coming to these tissues. So we have really to try to measure and estimate the tree, because we should not treat only contractility impairment. But when we have an impaired cardiac output, we need to know where it comes from. Is it preload? Is it afterload? Is it contractility? So that's why it is important to measure all these factors. And so this is why, indeed, we love to look at multiple variables. We look at cardiac index, and we look at ejection fraction or another index of contractility here. And of course, when we have here an impaired ejection fraction or impaired contractility, but cardiac output is preserved, well, we don't do anything. The tissues are happy here. We have to be cautious, because the heart may decompensate later on. But nevertheless, nowadays, we do not do anything to push the heart. Here, it's more trouble, because we have a low cardiac output, but a good contractility. So we need to do something else than giving dobutamine to this patient. We need to do something to try to improve, indeed, the cardiac output by more volume or maybe decreasing afterload, to do something on that way. And finally, we have here patients with low cardiac output, which is due to a low contractility. And in these patients, we may, of course, consider angiopic stimulation in these patients. And with this, I thank you for your attention.
Thank you very much, Professor De Becker, for that excellent presentation. Professor De Becker, as you know, is the past president of EICSCM, and he's been working as the head of the intensive care unit at the Schirach Hospital in Brussels, where he also heads the department. Thank you so much. Excellent presentation. If there are any questions for Professor Daniel De Becker, please put them on the question answer session, and we'll make sure that they are answered. Thank you very much. With that, I will close the session. We've had an excellent session on hemodynamic assessment and monitoring from expert international faculty. I will now hand over to the organizers, but please continue to put your questions on the chat if they're on the Q&A session, if there are any. Thank you very much.
So now we move on to our next session. It is a panel discussion. Weight of patient monitor parameters in ICU. A speaker for this panel discussion would be Krishna Prasad and Dr. Piyush Goyal.
Hello everyone, I'm Krishna Prasad. People know me as KP actually. I'm an anesthetist and intensivist. I have finished my MD from PGI a long time ago, and then I finished my FRC and worked as an intensivist and anesthetist in the UK. Now I work with the Hands-on Anesthesia Associates as one of the founding directors. I also do anesthesia as well as intensive care, nearly 50% of the time. I've always been interested in equipment, and I closely now, as a I have to release what I have been doing, that I'm associated with Stryker for developing and for improving the quality of weight measurement in the intensive care unit. And I do have very strong opinions that weight should be measured in intensive care unit. That has been a passion, and finally we have been able to do this. So I hope I will be able to talk a little bit about why I'm passionate about weight measurement in the intensive care unit.
Everybody, I am Dr. Piyush Goyal. I am Senior Consultant Pulmonology and Critical Care in Columbia Asia Hospital, Gurgaon. I have a rich clinical experience of 11 years right now. I did my MD in Pulmonology, completed in 2009. Then I did my FNB in Critical Care and Emergency Medicine from Sir Gangaram Hospital. Then I did my European Diploma in Adult Respiratory Medicine from Spain. And now I am heading a department of pulmonology and critical care in Columbia Asia Hospital. I am a member of Indian Society of Critical Care Medicine. Also, I am a member of European Society of Intensive Care Medicine. Along with, I am a member of Indian Chest Society and European Respiratory Society. Regarding my thoughts on weight measurement, this is a very important part of patient care. Right, and right now if you see, as globally it's a very difficult to measure weight for immobile patients, especially those patients who are bedridden, especially those patients who are critical, and especially those patients whom we are taking care in ICU. So weight measurement is a very important part. For example, I will enumerate some areas where weight measurement is absolutely essential. Accurate weight measurement is absolutely essential. Number one, first of all, nutritional plan of care. You can make nutritional plan of care only if you know the accurate weight, right? You want to know about total energy requirements of a particular patient irrespective of the clinical illness. Also, it depends upon the clinical status and the disease and the comorbidities. So you most of the time you calculate total energy requirement via Harris-Benedict equation, right? And so for that formula to happen, you want accurate weight assessment. If your weight assessment is not accurate, you are not able to make a nutritional plan of care. That is most important. Secondly, there are many drugs in ICU for which you need a dose titration, and dose titration you need is according to accurate weight basis most of the time. For example, heparin. If you want to give heparin to a patient, you need to know about accurate weight, right? If you are not taking accurate weight of a patient, you can give a drug in an underutilized manner, or you can give a drug in a overutilization manner, so that it leads to plenty of adverse effect, right? So this is one example. There are many drugs which need dose titration in ICU, and the top 10 drugs as per studies which need dose titration are dopamine, dobutamine, heparin, enoxaparin, propofol, and also there are some other drugs like vancomycin, gentamicin, and other antibiotics. So you need accurate dose assessment on a daily basis, right? So this leads to optimization of your drugs basically. Secondly, the adverse effects are more if you are not able to give dosages in an appropriate manner, right? Especially in oncological patients, especially in your elderly individuals or children and the neonatology patients. These patients are more prone to get adverse effects because of underdosages and the overdosages. Because their weight, also they are more vulnerable to weight changes in a very rapid manner if they are in ICU. So this is important, right? Thirdly, fluid management part. Fluid management, we all know as an intensivist, fluid management can be done in many different ways, right? You have a central venous pressure, CVP lines. You can use pulmonary PA catheters for that. You can use cardiac output monitors also for that. But the simplest way of measuring fluid assessment is daily weighing of a patient, right? So if you are doing daily weighing of the patient, especially in those patients like heart failure patients, in patients of who have a CKD, in patients who are on hemodialysis, you have to assess weight on a daily basis. There are many studies right now which shows that in a heart failure patients, if three things, first daily weight, second heart rate, and third BP monitoring is accurate, it will decrease your readmissions with congestive heart failure. Also, it will improve the mortality in patients. There are many studies regarding that, right? So weight is very important, and moreover,
Dr. KP, what are your thoughts on importance of weight measurement for critical care patients?
My thoughts about weight measurements in ICU, I think it's an important parameter. We virtually do everything based on weight, choose the tidal volume, choose the minute ventilation, estimate systemic vascular resistance, drug dosages. Everything is based on weight. And in order to calculate the BMI, etc., body surface area, we need weight. So it's surprising that weight is not is estimated rather than measured very commonly in the intensive care unit. So my thoughts are that maybe we are doing not exactly a scientific basis of dosing patients or doing all the critical care work without measuring weight in the intensive care unit. This is essential and it should be made popular, especially when patients are lying in bed for quite some time and nutrition becomes an issue. We need to know whether the nutrition is effective or not. So my thoughts are, putting it very, very crudely, is that maybe the treatment that we are giving is bordering slightly on quackery if we don't actually measure weight and estimate weight in patients, which has been shown numerous times not to correlate with the real estimate of weight. Dosages are based on kilogram per kg body weight. And logic states that we should be actually recording the kilograms of the patient in order to define the drug dosage of those patients. If we are not doing it, then a lot is left to be desired from getting the correct dosage of the patient, especially when a patient is very septic and you want the correct dose of antibiotics to be delivered to the patient, or you're giving chemotherapy for the matter, or that you are, achieving the tidal volume with these patients. You need an estimation of weight. It is very important. Correlation of weight and height has never worked out. By putting a scale along the bed and estimating the weight is useful in children, but it doesn't work in all patients. For example, you're dealing with trauma, where a patient is on splints, for example, or he's not able to get out of the bed to be measured, or he has lost a limb. So his preoperative correlation of the weight is not equivalent to the present weight. So even if we ask him how much did you weigh before, it doesn't correlate with what he is now. So I think a suitable continuous weight measurement in the intensive care unit, which is affordable and available to all, would be an excellent addition in the armamentarium for intensivists. So I should have mentioned about burns patient. I do not know if it is at all possible to manage burns patient in intensive care units without measuring weight, because every complete burn resuscitation is completely dependent on weight. The weight is wrong, resuscitation is wrong. So we need a system whereby we can actually maintain blood weight to the patient in order to give adequate fluids, blood, etc. to the patients.
Dr. Piyush, you talked about fluid management, but how do you assess fluid accumulation in ICU patients, and how does your plan of treatment change in case of patients where you observe fluid accumulation?
so as I told you earlier, fluid accumulation, we can see the fluid intake output balance via daily weight assessment, right? Now, there are many ways, I told you earlier also. So one of the ways is to assess the weight on a daily basis, right? Now, whenever we see a fluid accumulation, whether it is by intake output charting, whether it is by daily weight assessment, whether by any other technique you are using in ICU, so it will definitely change your plan of treatment as on a patient to patient basis. For example, if you have a ARDS patient in your ICU and he is on higher PEEP and higher FiO2 requirement, right? So fluid, you don't want to get into a fluid accumulation scenario. You want to get rid of this extra fluid, right? So the treatment, from a treatment point of view, you want to use diuretics for these patients. You want to restrict your fluid intake for this patient. Also, you have to change some settings of your ventilator so that patient again maintains saturations. You have to increase FiO2, you have to increase PEEP sometimes. So fluid assessment and is very important, and fluid overload you don't want in these type of patients. Similarly, in those patients who are CKD patients, you don't want these patients to be fluid overloaded. Moreover, in those patients who are on hemodialysis, and also before doing hemodialysis and after doing hemodialysis, you want to assess weight loss in a patient to see the effectiveness of your dialysis. You can't do RFTs on a daily basis with dialysis. So this is one of the important aspect of your effect of hemodialysis on a patient. Also, if you have a patient who is on ventilator with difficult weaning, you don't want fluid overload in those patients. You have to wean these patients after getting these patients dried up. You want some negative balance in these patients. So fluid assessment, fluid overload you don't want in these patients, and weight is one of the processes. Daily weight assessment is one of the simplest of the things which you can do so that you can eye on fluid overload status in your ICU.
Dr. KP, can you please explain fluid accumulation in critical care patients and what are the current practices to estimate the fluid accumulation?
The other issue has been about fluid accumulation over longer time when you treat rather sick patients. We know that sick patients accumulate fluid, and there has been so many therapies, treatments made on removing the edema and water accumulation in these patients, which is definitely shown to increase morbidity. But we rely completely on fluid charts to see whether fluid has the amount of negative balance achieved in this. It may not always be accurate because you have to correct it for insensible losses, etc., and then estimate whether the fluid has accumulated in the patient or not. And in an air-conditioned intensive care unit or underneath blankets, it's very difficult to measure and estimate the correct estimate of insensible losses. It's mandatory that we should measure weight in order to know whether the water that we are giving or the fluids that we are giving are accumulating inside the body. It may not be, a lot of studies have shown that this may not be exactly correlatable with the fluid charts, but this goes on the axiomatic truth that everything that is recorded in fluid charts is correct. It may not be, but it's required that a weight should also be used as a means of correlation along with IV fluids. There is one study in which was published, I don't recall when, but it just did show that in the first 24 hours, the correlation between weight and the fluid chart may not be great. But as the patient continues to stay in the intensive care unit, the correlation improves. That we all know that the longer the patient stays, the more is the fluid accumulation, and they become more, boggy and get more fluids in various organs. So it's difficult to estimate what it is, to get a quantitative estimate. And then we have rapid changes in fluids when you put them on dialysis, CRRT, etc. And sometimes people get boluses of fluids. So having a rough estimate or a good estimate of what is the weight gain is an important part of the entire part of critical care management. I'm actually surprised it's not done. The pediatricians always use it in neonatal intensive care unit. So I don't see any reason why we should not use it in adult patients.
Dr. KP, what about weight measurement of ICU patients who are on dialysis?
Like scuff, slow, continuous ultrafiltration, etc. A large amount of fluids or forced diuresis, a lot of fluid is actually removed from the patient. We do not know if that is causing a change in fluids. So especially when you're going on dialysis, going by the old formula that 1 ml of water is equal to 1 milligram, or 100 ml of water is 1 gram. So if you continue to, and 1000 ml of water is 1 kilogram. So if you're given a bolus of 1 liter of fluid to a patient, you have changed the weight of the patient by a kilogram. So in the course of the day, quite a bit of fluid is given to the patient, which may not be completely excreted. So a general weight of these patients helps in actually improving the quality of management in intensive care unit.
Dr. Piyush, your thoughts?
So moreover, also in dialysis patients, you want to estimate glomerular filtration rate by Cockcroft-Gault formula. You need accurate weight assessment, right? Then only you can see about the glomerular filtration rates, and accordingly you can modify your dosages and other medications and fluid therapy in ICU. So overall, if you see accurate weight assessment is very important thing, and it is very necessary because adequate patient care will need all these basic things.
So Dr. Piyush, what about the practices that you have observed?
Accurate weight assessment is a global problem in ICUs right now. Basically, we have stand-on scales, we have chair-on scales, we have bed-on scales. If you are talking about immobile patients, bed-on scales are most effective and most standardized, but they are very expensive. So it is not very cost-effective. It is not like the hospital management feels that it is not cost-effective to use them for each and every bed in ICU. So right now what we are doing is we are using stand-on scales for those patients who can stand, and we have chair-on scales also. But all these things need manpower. You need nurses to do that. And if you see globally, there are many studies which shows that this is the lifting of the patient and weighing a patient is the most stressful task it's one of the most stressful tasks for the nurses. So it is not easy to accurate weight measurements right now. We are using some formulas of ideal body weight and predicted body weight right now. So accordingly we are giving. But as I suggested, that daily weight assessment is important for good patient care in ICU. So it can't be done on a daily basis right now. Moreover, there are many issues regarding daily weight assessment. One is the nurses, I told you. Second is the manpower. Third is most of the admissions in my hospital are from emergency department in ICUs. And in emergency department, most of the time nobody is bothered about the weight of the patient when the patient is coming in the critical situation. And also many of the admissions are not at that point of time when you are there to get these things checked up. So they are admissions in evenings, nights, so you are not able to get to the weight of these patients many times. So it's a major problem right now.
So Dr. Piyush, you mentioned the issues with the nursing staff and manpower. Will standardization of protocols help in better compliance, and how do we partner with the nurses for the same?
Standardization of the protocols, so that will definitely improve the compliance. There are many studies which showed like that. But before making a protocol, you have to aware nurses regarding the importance of accurate weight assessment. This is very important because nurses are not able to make it realize that it is very important to assess weight in an accurate manner. And we can make protocols. We can tell them the pros and cons regarding if you are not doing accurate weight assessment. The dietitian will take a part in this. The physiotherapist can also take a part in this process. The nurses have to be very sensitized, should be sensitized regarding proper measurements of the weight. So it can happen. Standardization of protocols will lead to proper compliance, good compliance.
Dr. KP, can you please talk about some of the best practices that you've seen that are followed across the world, and what are the constraints and challenges in some of these existing solutions or practices that are followed?
Best practices, I have worked abroad and I've worked in burns intensive care units. As I said, many of the burns intensive care units actually had a weighing system incorporated at the door of the intensive care unit. That when a bed is passed over it, before the patient is admitted, a weight can be estimated. But that is only in one place. And cranes are not of much value because when you're dealing with high percentage burns, putting a crane hoist with its nylon, etc., underneath the patient and lifting them is sometimes not easy to manage. And tracking the weight regularly becomes an issue. It needs at least a couple of people to roll the patient around, put the hammock underneath. There are logistic issues about it, especially if the patient is extremely obese. These things become a major problem. Cost is a major barrier to these things because cost and the logistics of use of these things become an issue. The high-end beds are already available with weight incorporated into it, but they are high-end, they are expensive. And we don't know how many small, medium-sized intensive care units can have all their beds have this particular incorporated weight measurement built into the system. So as I said earlier, that we need a system which the weighing system can be transferred from one bed to other, and if necessary, instead of having all the beds with the weighing capacity. And the sickest patient can always have this method of weighing, and it can be removed from underneath the patient, incorporated into another bed if needed, and easily sterilizable. I think that is what is needed at this present point of time.
Dr. Piyush, apart from nursing and manpower issues, I heard you mention cost of equipment is the other major barrier. So if there is a cost-effective and simple solution, will it help in standardization?
You need something that is cost-effective. You need something that is standardized. You need something that is easy to do. Nurses have no problem in doing that, and they are able to get it in an easy way. So then only we can make a protocol to do weight on a daily basis, and this thing is a need of ours, I think.
Dr. KP, Dr. Piyush, what would be your concluding thoughts?
Well, I mean, as an intensive care unit in charge and as well as being an intensivist, also as an anesthetist, it's extremely frustrating that we do not know what is the weight of the patient in order to give an induction drug or whatever to maintain the patient. So without weight, the fact that we are managing all these days without weight is itself very surprising, and that we have not been able to create a low-cost, easy-to-manage weighing system in the intensive care unit, despite advanced so much into hemodynamic monitoring, spending enormous amounts of money in this. And there is no reason why this weight cannot be incorporated into the dialysis machine with a targeted closed-loop system, that we have to achieve this amount of weight in the body, or management of heart failure patients. So I personally think, and the other thing comes in is that during this present pandemic times, patients are there in the intensive care unit. You cannot have one unit that is stuck to one bed, or you have a crane that is moving, because there's a contamination issue as well. So I think we should encourage the industry, or even push the industry to create low-cost solutions for us, so that we can measure weight inside the intensive care unit, or in the emergency room, or in the pre-operative areas and in the post-operative areas. I don't see any reason why it should not be available on every bed, inside every hospital bed inside the hospital. The pediatricians are running pediatric intensive care units. Their neonatal units have weight incorporated into their cribs. I don't see any reason why we should not be having that luxury too.
The conclusion of my talk is we have to have something in our ICUs for accurate weight assessment. That is very important. We have to sensitize ourselves regarding weight assessment in ICU because it is very important. As we know, nutrition is important. There are many guidelines regarding nutrition in our critical care. So there should be a guideline for weight assessment also, and also drug dosages, dose optimization, dose titrations are very important part of intensive care. So it can't be done without weight assessment. It is very important. Also, your morbidity, mortality, and your prognosis depends upon fluid assessment of a patient, whether it is a positive fluid balance, whether it is a negative fluid balance, whether it is fluid overload, whether the patient is fluid depleted. So for all these answers, you need a weight assessment in ICU. Moreover, especially for elderly individuals, especially for your oncology patients, especially for your pediatric and neonatology patients, weight measurement on a daily basis is absolutely essential. So my point is to make you aware regarding weight assessment. I want to sensitize you from the day onward. You have to take care of weight assessment. You have to stress upon weight assessment in your ICUs. Thank you.
Dr. KP, Dr. Piyush, it has been great to hear from you today. I hope the audience has also found the session useful. To conclude, weight is an important parameter for ICU patients. It is useful for nutrition management, fluid management, drug dosage, tidal volumes, fluid resuscitation. Also, the current methods of weight measurement leave a lot to be desired, and doctors feel that standardization of equipment will help in better protocols and adoption, leading to better patient care. Please drop by our virtual booth after the session to get more information.
After such an informative panel discussion about the monitoring of the weight of ICU patient, next we'll move on to the one more parameter related to the monitoring, especially ventilatory parameters, that is the driving pressure. How and when I use driving pressure in ARDS, that is the title of our next talk, and Dr. Lauren Brushard would speak about this driving pressure.
Hello, everybody, and thank you for this invitation to this workshop, which will be about the use of driving pressure in ARDS with some theoretical, but also a lot of practical consideration and recommendation. These are my conflicts of interest. I'm working with a number of companies to get grants or equipment. And let's start a little bit about simple theory and principles. So the basic principle is that in ARDS, CT scan have repeatedly shown the importance of gravity on the distribution of the injury, and the lung is more or less often distributed into a part which is not aerated, which we could call the atelectatic part, and a small part which is aerated, and which we call the baby lung. And the atelectatic part is huge. Maybe it does not look so big on the CT because it's again compressed and atelectatic, but if you think of the volume here, maybe the the atelectatic part represent at least 2/3 of the normal lung. So it's really a baby lung. And what we have noticed since first CT scans were performed by Luciano Gattinoni and his group was that the lower the baby lung, the smaller the aerated lung on the CT, the higher were the pressure on the ventilator, the higher was the elastance, or the lower was the compliance. And you see this nice correlation between compliance and the aerated lung, the baby lung. So if you think of compliance, which is the volume over the pressure, it's an interesting way to express this for the reason I'm going to explain. So let's think of a patient who is not in a bed, who is not in the ICU, is standing up. You measure the compliance is 100 ml per centimeters of water. This means that it's equivalent to having 100 some small units in the lung, all put together, and each unit having 1 milliliter per centimeters of water. Okay, so this is not one alveoli, but maybe one alveoli bag, something like that. Each one as 1 milliliter per centimeter of water. Now, if you think of the same patient with the pneumonia we have seen of the CT scan, you know, maybe 30 units will be left open. The rest is closed, is atelectatic. And very simply, the compliance for these patients will be only 30 ml per centimeters of water because you have only 30 units left open. So that's what really is interesting in compliance, is that it's directly proportional to the size of the aerated lung. It does not tell you anything about what's happening in the atelectatic or injured lung, but it tells you the size of the baby lung. And therefore, compliance is proportional to the lung volume, right? To FRC, what I wrote here. And compliance, to get the measurement, you divide the volume, the tidal volume, by the elastic pressure, which is classically measured at the difference between the plateau and the PEEP, which we call the driving pressure. So compliance is tidal volume divided by driving pressure. And if you reverse the equation, driving pressure is tidal volume expressed to compliance, tidal volume to compliance. So driving pressure is a way to express the tidal volume you set compared to the size of the baby lung. So this is a really interesting approach because it tells you what's the ratio between what you give and what is left for ventilation. So we now have a lot of clinical data. I'm not going to go through everything, but of course the first real important paper was a brilliant study by Marcelo Amato, and who has been working with a lot of people to get a lot of database from different studies. And he was exactly thinking about that the ratio of volume to compliance would indicate the functional size of the lung and could provide a better predictor of outcome for patients with ARDS. And it turned out in this study that this was by far the best index associated with outcome, more than tidal volume, than plateau pressure, than PEEP, than oxygenation, etc. And you see this nice graph where the increase in driving pressure is associated with a change in the outcome, less driving pressure, better survival, high driving pressure, increase in mortality, and it seemed the cutoff is around 15 centimeters of water. So we already have something very, very pragmatic to use at the bedside and to remember. Around 15, the driving pressure, when it's above, we may be concerned and maybe we have something to do. And they nicely demonstrated that it may be more important than the plateau pressure. Of course, we have to be careful because this is within the framework of randomized trials, which relatively control the plateau pressure. So, but you see that if the driving pressure is going up with the same PEEP, you increase mortality. If the driving pressure is if the plateau pressure is going up, but the driving pressure is the same, you do not change mortality. And if you keep the same plateau, but for higher PEEP, you have less driving pressure, you decrease mortality. So maybe really very important to monitor this paper. And this was the data from the randomized trial. This is data from clinical setting. This is the lung safe study, which is an observational study, which already which found that again the driving pressure, and here the cutoff maybe was slightly better at 14 instead of 15, really separated the outcome. The lung safe showed that if you look at the global relationship between mortality and plateau, it seems to be increasing for plateau higher than 30 to 35. But driving pressure, it seems to be a more consistent association, like between 10 and 35. So driving pressure seems to be a very potential indicator of the risk of death, which suggests the severity of the patient, but also the risk of maybe ventilator-induced lung injury. Is the driving pressure measured on the ventilator the best indicator, or should we go for the lung driving pressure, which uses the transpulmonary pressure and which needs the esophageal pressure? Well, maybe the lung driving pressure, if you think of ventilator-induced lung injury, could be the more logical way to estimate the driving pressure. This was nicely done by this analysis done by the group in Boston, Elias, Bedford, Cassis, and colleague. And they show that if you look at the difference between survivors and non-survivor, looking at the respiratory system driving pressure, so the one we measure on the vent, and the transpulmonary driving pressure, well, it's hard to say whether one is better than the other. So there were some small advantages of the transpulmonary driving pressure, but for the purpose of the prognosis, not sure that you get so much more information with the esophageal pressure. So only with the pressure on the vent, you can get really important information. And this is one of the most recent study, which really is interesting because this is a registry we have in Toronto, where we put all mechanically ventilated patients. So it's not only ARDS, and it's also every day on the ventilator. So the study was able to look at the impact of driving pressure longitudinally, day after day, and in all mechanically ventilated patients. And you find again this type of curve, which maybe there is something relatively flat here, but goes up clearly above 15. And if you compare the mortality of patients below 15 or above 15, there is a very, very large difference in the mortality. So this is the static driving pressure at baseline. So really important data confirming after a lot of other data that this is a major, at least a major monitoring tool that we should use in the ICU. Okay, let's go to some very important practical consideration about measuring this simple index. I say simple, and I think it's important to try to keep it simple. So when you measure it, this is a classical waveforms we see on the ventilator, the flow, the airway pressure. Here we have the esophageal pressure and the transpleural pressure, but I already mentioned that it may not be absolutely mandatory for monitoring driving pressure. And the PEEP should be ideally the total PEEP. So if you have some intrinsic PEEP, it's better to get the total PEEP, which is the real, potentially the real alveolar pressure. And there may be some differences, for instance, between LungSafe and other studies, whether they measured the PEEP tot or not. Regarding the plateau pressure, we have been told for many years that you can do this long plateau where the pressure slightly goes down. There is a kind of stress relaxation of the system. And at the end of a long pause, the plateau may be significantly lower than just after a very short pause. After a very short pause, like 0.2, 0.3 seconds, it's very convenient because you can get it at every breath. That's what we do in my center. We always have a plateau in volume control, but the value may be slightly different after a long plateau. Which one should we take? I strongly believe we should take the simple one, because we measure the peak alveolar pressure, which is probably what matters the most regarding the risk of injury. So it has two major advantages. First, it's probably more accurate to take the short pause. And second, it's much simpler to do. You can get it at every breath. So I don't think there is any reason not to measure and monitor driving pressure and plateau pressure in the ICU. The second thing is, what is the real alveolar pressure? So I mentioned already auto PEEP and total PEEP. So if it exists, that should be taken into account. But in ARDS, we have another phenomenon which is called airway closure, and which makes things a little bit more complicated. It's not in every patient, but it's quite frequent in maybe 30 to 40% of the patients. What is it? Well, this is what you get when you do a very low flow inflation. We call that a pressure volume curve, okay? You very slowly inflate the lung. You see the pressure going up at the same time the volume is going into the lung. And you may have this type of curve, which looks relatively linear here. And the slope is a compliance of the respiratory system. In 30 to 45% of the patients, you don't see that. You see this kind of curve. What is it? Well, the first part of the curve is very, very flat. And what we did here is to compare the first part of the curve to simply the compliance of the tubings, of the circuit. Okay, if we occlude the circuit, this is what we see. In other terms, the first part of the inflation, until a pressure of 16 centimeters of water, is not inflating the lung. And it's not because the lung is collapsed. The lung may be collapsed, but it's not the main reason. The main reason is that because the airway, probably the small airway, we are not sure, closed. Okay, so you still have gas in the alveoli, but your airways are closed. So it's very important to get that for two reasons. One is that this is your true alveolar pressure. This is not your PEEP. This is not, it's not your PEEP. It's not your auto PEEP. This is the real alveolar pressure. So if you measure the driving pressure, you should better know this pressure. Otherwise, you may be really, it may be misleading. And you don't need to do a PV curve. You just need to do a pressure time curve, like here. Again, the flow, the airway pressure. You see, we put the respiratory rate very low. We put the flow lower than 10 liters per minute. And you have this biphasic curve. The first part, very, very steep increase in pressure. Second part, a very normal inflation curve. So the first part is when you still have airway closure. And this point where the two curves change is your airway opening pressure. At which pressure do the airway open? And we use it clinically to say, well, this is where we should put the minimal PEEP. Okay, so in this patient, it was 18. So nothing was entering the lung until this pressure was 18. Okay, so that's a bit more complicated, but important. And in case of auto PEEP, the real alveolar pressure, remember, is a total PEEP. In case of airway closure, the real alveolar pressure is AOP, the airway opening pressure, not the PEEP. Excuse me. Okay, next information. This is what you get. What everything I've described is for passive ventilation. Well, the good news is that this is also something you can measure during assisted breathing. And this is an example during pressure support ventilation. Very nice paper by Giacomo Bellani, who indicated here on the left the situation of, let's say, pressure control. The patient is passive, you do plateau, it goes down, right? So again, during pressure control, you can have a plateau which is lower than the peak if the flow does not reach zero before the next breath. But in pressure support, because the patient is actively breathing, the total distending pressure is higher than the pressure delivered by the ventilator. So in pressure support, if you do a plateau, you may see a higher value than the peak pressure. It may look surprising to you, but I will show you another example. This is the sum of the pressure delivered by the ventilator plus the sum of the pressure which has been generated by the respiratory muscle at the end of the inflation when the patient relaxes. So you have to be sure that the patient relaxes, that the patient is not activating expiratory muscle. But this is true in maybe 60, 70% of the case. If you have a flat line, it's a good sign. For instance, this is a nice tracing in a patient. And you see from the esophageal pressure that the patient is relaxed. And this is a true plateau pressure during pressure support, which clearly is higher than the pressure set on the ventilator. And why is it interesting? Because in their centers where they use pressure support very early, they found that the mortality was increasing with the driving pressure. This is quartiles of driving pressure, but not with the quartiles of peak pressure. So it seems even during pressure support, it's a good indicator of the elastic pressure on the lung and still a prognostic indicator. Okay, let me finish with some drawbacks about driving pressure, which are very important to know. I took the example of what was called the stress index to try to make you understand why in some situations the change in driving pressure do not reflect the best recruited lung. So the people who have described the stress index say, well, if you have constant flow ventilation, when the compliance is constant, the stress index is 1, and you see it's a straight line, right? The pressure goes up linearly. When you over distend the lung, your curvature will be an upper curvature, your stress index will be higher than 1. And your driving pressure will go up, of course. But if you are recruiting the lung during the inflation, so that's what we call tidal recruitment. During insufflation, you're recruiting the lung, which we think is bad because at the next expiration, this part of the lung will collapse. Okay, so reopen, collapse, reopen, collapse. Remember when we said PEEP, we want to reopen the lung, but also to keep the lung open. So this is a lung which is not well recruited and is recruited during the inflation. This will give a stress index below 1. This will decrease your driving pressure. So the driving pressure will be lower when the lung is recruited during inflation than once the lung has been recruited. Okay, so if you wish, this is a driving pressure before recruitment, you increase PEEP, you recruit the lung. Now your stress index is equal to 1, but your driving pressure will go up. So the driving pressure, when you change PEEP, this is specific to change in PEEP, may be misleading. And in fact, in a recent study where we describe a new way to assess recruitability at the bedside, the recruitment to inflation ratio, when we look at the high recruiters, well, they on average increase oxygenation with higher PEEP. They have no hemodynamic effect. But if you look at their compliance and therefore their driving pressure, the compliance was lower after recruitment. So the fact that your driving pressure goes up a little bit does not eliminate the possibility that in fact you have recruited the lung. So recruitment does not always mean decrease in driving pressure. Of course, it was worse in low recruiters, but individually, it's not a good index to say the PEEP is good because I've decreased the driving pressure or not. Yes, when you decrease the driving pressure with PEEP, it's good, yes. But if it doesn't change or even if it's slightly increased, you may still recruit the lung. So to conclude, I think the driving pressure in ARDS is really useful. Well, first to recognize the ARDS, right? When you set your tidal volume as 6 as a default value, as we do in our ICU, if your driving pressure are between 10 and 15, you say, well, this lung is relatively small, so it may be ARDS. Then it gives you a relatively precise idea of the severity, the mechanics severity, and the estimate of the baby lung. And although we do not have prospective data where the tidal volume is targeted to maintain the driving pressure, it may help you to better individually titrate tidal volume. Okay, if you've done everything and your driving pressure is 18, I would suggest that you may consider to go lower on the tidal volume if possible. But the driving pressure in the ARDS should not be used to titrate PEEP for the reason I explained. And the good news is that the driving pressure can also be measured during pressure support ventilation. Okay, I hope you found this presentation useful. I invite you to follow our blog, coemv.ca, for further discussion on
After the very enlightened talk on driving pressure, our next talk is on the passive leg raising test, and it would be delivered by Dr. J.L. Topol.
Hello everyone, I am Jean-Louis Teboul from Paris, France. I am very honored to participate in this meeting, and I thank a lot the organizers for their kind invitation. First of all, I would like to declare my conflict of interest, and I would like to start this presentation by a few words about physiology of passive leg raising, PLR. As you know, PLR is a maneuver consisting in moving the bed of the patient, not the patient. Moving the bed from the semi-recumbent position to a position where the head and the trunk are horizontal and the legs elevated at 45 degrees. And this can transfer venous blood from the legs and abdominal compartments towards the intrathoracic compartment. And this should increase the mean systemic pressure, which is upstream pressure for venous return. And with Laurent Guérin, Xavier Monet, and others, we performed a clinical study where we estimated the mean systemic pressure, PSM, during PLR just before giving fluids to patients. And we subdivided the patients into groups, fluid responders and fluid non-responders, in function of the response to fluid administration in terms of increasing cardiac output. And what we found that PSM increased during PLR in both fluid responders and non-responders. We found similar results for CVP, which also increased with PLR in fluid responders and non-responders. And we looked at the difference between PSM and CVP, which is more or less the venous return pressure gradient. And this difference increased only in fluid responders during PLR and after volume expansion, and did not change in fluid non-responders. If I summarize the hemodynamic effects of PLR, I would say that PLR increases the mean systemic pressure in prelude responders and non-responders. PLR increases the CVP in prelude responders and prelude non-responders, and PLR increases the venous return pressure gradient only in prelude responders. In other words, PLR mimics a fluid challenge, and therefore the hemodynamic response to PLR should predict fluid responsiveness. So the first advantage of PLR is to provide a good prediction of fluid responsiveness. And this is well illustrated by this meta-analysis we performed with Paul Merrick and Xavier Monet. We included 21 clinical studies that all address the issue of prediction of fluid responsiveness by PLR. Almost 1,000 patients were included in this meta-analysis, and we found that the changes in cardiac output during PLR very well predicted fluid responsiveness within a summary area under the ROC curve of 0.95, which is excellent. Another advantage of PLR is that, unlike fluid challenge, its effects are rapidly reversible. I would like to refer to this old study we performed with Thierry Boulin and others in our unit, where we measured the cardiac filling pressures, right atrial pressure and POP using the Swan-Ganz catheter before, during, and just after PLR. As you can observe, in almost all patients, the cardiac filling pressures increased during PLR and returned to baseline values just after PLR. So the PLR test is reversible. Another advantage is that PLR can predict for responsiveness in situations where PPV fails to do it. PPV is pulse pressure variation. As you know, this is a change in the pulse pressure during mechanical ventilation, and a high PPV is generally associated with prelude responsiveness of the heart. And in this situation, the patient should respond positively to fluid administration if you give fluids. And the opposite is true. A low PPV is generally associated with prelude unresponsiveness, meaning that if you give fluid to patients, the patient would not respond to fluid administration. But of course, if you have a low PPV, please don't give fluid to patients. And in the past, more than 20 years ago now, with Frank Michard and other colleagues from my unit, we showed that pulse pressure variation PPV was far better than CVP and POP to predict fluid responsiveness. Look at the large area under the ROC curve for PPV. And there are many limitations of PPV in the ICU patients. We have some false positive cases, false negative cases, in particular in patients with spontaneous breathing activity. And in these patients, probably PLR better predicts fluid responsiveness than PPV. It is well illustrated by this study we performed with Xavier Monet and others in my unit, and we included only patients with mechanical ventilation, but with persistent spontaneous breathing activity. And we compare PPV and PLR to predict fluid responsiveness in these patients. PPV did not predict fluid responsiveness at all, with a very low area under the ROC curve, but PLR predicted fluid responsiveness with a good sensitivity and good specificity. Of course, we look at the changes in cardiac output during PLR. Another situation where PLR can predict fluid responsiveness is low lung compliance. In this situation, PPV does not predict very well fluid responsiveness. In this study, we performed in ARDS patients with low respiratory system compliance. PPV did not predict very well fluid responsiveness. Look at the area under the ROC curve, which is 0.69, while the PLR predicted with a very good accuracy. The area under the ROC curve is 0.94, which is an excellent area under the ROC curve. Another situation which is interesting to use a PLR is to decide fluid removal, for example, at a late stage of ARDS patients. We performed a study with Xavier Monet and others in our unit where we performed a PLR test just before fluid removal. And we look at the hemodynamic effects of fluid removal. And we found that when a patient has a positive PLR test before fluid removal, generally the patient experiences a hypotension during fluid removal. And the opposite was true. In other words, if you have a negative PLR test, this may encourage clinicians to apply a fluid removal strategy, but fluid responsiveness should be tested and retested frequently, of course, using PLR. And finally, PLR was shown to be associated with a better outcome versus CVP in a single center randomized controlled trial, including septic patients. This is a study performed by Jean-Christophe Richard and the team of Claude Guérin in France, and the authors compared two strategies, two fluid management strategies. One was based on results of PLR tests repeated frequently, and one, it was a PLR group, and one was based on measurements of CVP and MAP. It was a randomized study, 30 patients in each group. There was a difference in terms of survival, but as you can observe, this difference was not statistically significant because the p-value is just above 0.05, probably due to a lack of power. But what was interesting was the changes in blood lactate, and lactate decreased more and earlier in the PLR group compared to the control group. So it is an interesting result in favor of the use of PLR. Because of all these advantages, the Surviving Sepsis campaign in 2016 regarding septic shock patients recommended to use passive leg raising to predict fluid responsiveness. So this is an interesting recommendation. Of course, we have to respect some rules when we use the passive leg raising test. First, sympathetic stimulation must be avoided. So we need to move the bed and not the patient. We try not to touch the patient, not to cause harm, pain, or stress to the patient. So we recommend to monitor heart rate to be sure. And for example, if heart rate doesn't change, you can rely on the PLR test because probably in this situation, the sympathetic stimulation is not very strong. Also, PLR should not start from a horizontal patient's position, but from a semi-recumbent position. This is what we demonstrated with Julien Jabot and Xavier Monet and others in this clinical study. We compare two PLR tests one starting from a horizontal position and one starting from the semi-recumbent position, and only the PLR test starting from a semi-recumbent position could mimic fluid administration of 500 ml. So we recommend to use the PLR test starting from the semi-recumbent position. Third, the hemodynamic response to PLR cannot be assessed by the changes in arterial pressure. Indeed, in this meta-analysis I already talked about, we also looked at the changes in arterial pressure, and mainly pulse pressure, but also systolic pressure, and we found that the area under the ROC curve, the summary area under the ROC curve for the prediction of responsiveness using changes in blood pressure was not satisfactory enough. We found a value of 0.77. So we cannot use reliably the changes in arterial pressure to assess the effects of PLR. And this result was essentially due to false negative cases. Fourth, the hemodynamic response to PLR cannot be assessed by the changes in CVP. And this is illustrated by this recent study we performed with Alfa Hamzawi and others in our group. We looked at CVP before PLR, and we looked at the changes in CVP during PLR. And unfortunately, neither CVP before PLR nor the changes in CVP during PLR can detect fluid responsiveness. So we cannot use the changes in arterial pressure. We cannot use the changes in CVP, so we need to use the changes in cardiac output. But because the effects are transient, a real-time cardiac output monitor is mandatory, and this is what we emphasized in this editorial we wrote some years ago with Xavier Monet. An important limitation is the presence of intra-abdominal hypertension, because PLR may be unreliable. And this is illustrated by this recent clinical study we performed in our unit with Alexandra Burton, Xavier Monet, and others. We included two different categories of patients: patient without intra-abdominal hypertension and patient with intra-abdominal hypertension. In patients without intra-abdominal hypertension, the prediction of responsiveness using PLR was excellent, a very good value of area under the ROC curve. But in patients with intra-abdominal hypertension, the prediction of responsiveness using PLR was very poor, with an area under the ROC curve of 0.60, and we concluded that there is a poor ability of PLR to predict responsiveness in patients with intra-abdominal hypertension, essentially due to false negative cases. So my conclusion, PLR is an excellent fluid responsiveness test. It mimics free challenge without any drop of fluid. It is easy to perform. It is reliable in patients with or without mechanical ventilation. Whatever tidal volume like compliance, presence of arrhythmias, but it requires a real-time cardiac monitoring to assess its effects. We cannot rely on changes in arterial pressure, or we cannot rely on changes in CVP. The only limitation is the presence of intra-abdominal hypertension. So if you suspect intra-abdominal hypertension, please measure abdominal pressure before performing the PLR test. Thank you very much for your attention. I also would like again to thank the organizers for their kind invitation.
Thank you, Dr. Tabul, with such an excellent presentation on PLR, its use, as well as the constraint in the different clinical situation. In fact, the PLR is one of the common hemodynamic monitoring which we use in the ICU for the bedside assessment of the hemodynamics. With this, now we move on to the next. In fact, it is the last segment of the session, as well as the last part of the conference as well, in the form of pro and con session. That is, the procalcitonin has crossed its use by date in ICU, and the speaker for the session in pro, Dr. Gunjan Chanchalani, and for con, Dr. Mozamil Shafi will speak about it.
Hello everyone. Thank you for inviting me for this congress. So we has crossed its use by. I'm going to talk on the pro of it. It's used by date. Procalcitonin till date. So there's a positive correlation with patients with positive and sepsis. It in viral infections following administration of appropriate but what do we also need? Also become elevated among patients conditions such as those with many carcinomas, patients and also it may patients suffering from various degrees of kidney and in turn alter the baseline result the determination of an underlying bacteria. 2013 systemic review and meta observational ICU and shows that the sensitivity of procalcitonin % and specificity. So though it is for identification of sepsis with the context of clinical presentation that you have to carefully interpret it with the presentation. The role of procalcitonin as a diagnostic. So its use as a diagnostic tool remains. Again, as I said, it has a very low sensitivity size cutoff value. Different studies have, if you ask different clinical values, it does have a good negative, especially for bacteria. Evidence does not hold, which can exclude bacteremia. Of 25 studies with almost 2006 could be used as a quick and in critically non-immuno. However, its role in detecting improvised patients remains controversial. These have shown many conflicting results. So let us talk about antibiotic. A lot of people use levels to initiate antibiotics. The multi-center randomized 14 emergency departments in the EU because they believed in starting antibiotics in itself when the patient came. Only adult patients with only 1,100 patients. They found in groups in mean antibiotic. Okay, so the total amount what did not differ whether you did. Okay, when they did the analysis, they found that it was a reducing antibiotic exposure in patients, but then in other pneumonia and asthma not found to be very useful. In emergency department antibiotic subgroup, they also found that subgroup there was no significant at day 30. Guidelines say the idea is for the treatment of CAP against using procalcitonin in the disease. The use of diagnosis to initiate antibiotic benefits in the clinical outcomes and antibiotic exposure and antibiotic outcomes is conflicting. Information, the use of procalcitonin to initiate antibiotics can. Now let's antibiotics. A lot of people decreases to 80% or peak procalcitonin value. Then antibiotics. So this 20 meta-analysis, which almost 10 3,500 ICU patients, guidance did reduce antibiotic 1.49 days on mortality or mortality of ICU stay. The same year, another meta-analysis with 11 RCTs showed that this reduction in antibiotic duration was only by 1.19 days, and it had no difference in the length of ICU stay or hospital stay. The next year, there was another meta-analysis which was focused on PCT-guided antibiotic discontinuation and mortality in ICU patient. It probably sought to resolve and understand the discrepant mortality findings which the prior meta-analysis had. And this now had 16 RCTs with 5,000 plus patients. They found that PCT-guided antibiotic discontinuation was associated with some amount of mortality risk reduction and antibiotic duration, but again, by only 1.31 days. However, the authors also say in the same paper that this represents only low certainty evidence with a high risk of bias, and that this decreased mortality was not found in patients with sepsis, in patients with trials with high PCT guidance algorithm adherence, and trials that used PCT guidance algorithms without the CRP. So as a sole marker, when you used it, it was probably not that effective in reducing mortality. So the systemic reviews found a decrease of 1 to 1.5 antibiotics days with the use of PCT-guided antibiotic therapy in ICU patients with a null or small survival benefit with no evidence of harm. So now let's next review the 4 largest individual RCTs done in critically ill patients of PCT antibiotic guidance, where the primary goal was only antibiotic reduction. So there is this study called as PRO-RATA, which is a randomized prospective open label trial, which was done in 7 ICUs in France. Critically ill patients with suspected bacterial infections who had received antibiotics for over 24 hours were included, and almost 621 patients were included, with 307 in the procalcitonin group. All these patients were mainly medical patients. They had excluded patients with neutropenia or patients who had been on long-term antibiotic therapy or who would require as a standard therapy, which is endocarditis. So here they assessed PCT daily, and they created levels at which the antibiotic should be discontinued. So as you see, out of the 307 patients, 219 episodes, this guidance of stopping antibiotics when the PCT levels reached less than 80% of peak or less than 0.5 micrograms per liter, this guidance was not followed. So mortality met the non-inferiority margin of 10%. However, the point estimates for mortality were higher in the PCT group versus the control. And there was no difference in the proportion of patients with emerging multi-drug resistant bacteria from clinically obtained specimens. The next study is the PROGUARD study, again a multi-center prospective single-blind randomized trial in 11 ICUs in Australia. This had 394 patients, all were critically ill with suspected bacterial infection, receiving antibiotics, and more than 2 source criteria. PCT was measured at randomization and then daily until ICU discharge, or up to 7 days, which came first. The primary outcome of median number of antibiotic days at day 28 did not differ between these arms, nor did the 90-day mortality. Next, another trial of 2016, a multi-center placebo-controlled randomized trial, again including almost 1,000 patients with 552 in the PCT group. This trial was the only RCT actually powered for mortality. And here again, they did a serial measurement of procalcitonin, and they used the guidance to optimize the antibiotic therapy as well as the source control and as well as to discontinue antibiotics. They found that PCT guidance did not reduce mortality or the antibiotic cost, but they did find that it was associated with a 4.5% reduction in the antibiotic exposure. The SAPS trial, another multi-center randomized trial with almost 1,500 patients, they tested the superiority of PCT guidance for antibiotic exposure, and they found a significant reduction in the median antibiotic days in the procalcitonin group, which was 5 days compared to control groups. That means a reduction, absolute difference of about 1.2 days. But the authors also reported an unexpected finding of reduced 28-day mortality and postulated that PCT levels may aid in consideration of alternative diagnosis when low and optimization of infection management when persistently high. However, when this trial was critically analyzed, it was found that if 9 patients in the intervention arm changed from survived to died, the survival benefit would no longer have been statistically significant. So for discontinuation of antibiotics, as we know, the role of PCT, it did not really reduce the number of antibiotic days, but it did show a reduction in risk of antibiotic-related Clostridium difficile diarrhea, emergence of antibiotic resistance, or overall, it did not fail to show a reduction in the risk of antibiotic-related Clostridium difficile diarrhea, the emergence of antibiotic resistance, or overall mortality. So what do the guidelines say here? The IDSA and the ATS guidelines for the treatment of VAP and HAP and the Surviving Sepsis Campaign guidelines give a weak recommendation based on low quality of evidence that procalcitonin levels can be used to discontinue and empiric antibiotics. Please note here, it is a low quality evidence and it is a weak recommendation. So what are the limitations of procalcitonin that we need to consider? So falsely low procalcitonin is seen in majority of localized infections like cellulitis, appendicitis, abscess, and empyema, which can be misleading. Interpretation of procalcitonin levels can be difficult in patients with severe trauma, major burns, multi-organ failures, islet cell tumors, and medullary thyroid carcinomas. It is also important to acknowledge that cellular injury of any kind, whether direct tissue injury or ischemic reperfusion injury without infection, can also result in an elevation of PCT. And highly elevated bilirubin and triglyceride levels also interfere with the procalcitonin level measurements. And most importantly, which is very important in our ICU patients, is that serum levels of procalcitonin increase in patients with deranged renal function. And as we know, there is a very high incidence of renal failure in patients which are admitted to our ICUs. So the utility of procalcitonin becomes highly limited. While some studies also report that in these patients with renal failure, including those who are on hemodiafiltration, we could have a higher threshold, a different threshold for diagnosing bacterial infection. But again, this cutoff for procalcitonin levels might need to be adjusted in patients with different levels of renal function. So you do not really have a fixed cutoff that at this creatinine level or at this level of renal function or GFR, we would use as a cutoff. And coming to the cost, though we do not have any per se study in India which talks about the cost of procalcitonin when we use it in the ICU, the study clearly says that procalcitonin users suffers from overusage in the emergency and ICU setting, which leads to extraneous costs. And the Salinas et al. In 2018 said that almost 1,42,000 procalcitonin assays performed in the calendar year, 44% could have been easily avoided based on clinical presentation and outcome, which could have saved them up to $6 lakhs annually. So within the ICU setting, another randomized controlled trial was performed to determine the cost effectiveness of procalcitonin assays among septic patients. They found that the cost per patient could have been was average $2,700 greater than the patients who did not receive the procalcitonin assays during the hospital stay. Therefore, clinicians need to use precaution when ordering procalcitonin assays to ensure cost-effective medical practice. And now I give it to Dr. Mozammil to please speak about the con.
Okay, thank you very much, Dr. Gunjan, for your nice presentation. So I'm going to speak on the con part of that, which is procalcitonin has not crossed its use by date in ICU. So we know that the ideal characteristic of the ideal biomarker that it should be present at symptoms onset and allow for the early diagnosis. It should be being highly sensitive and specific for the infection. It should be capable of identifying the causative organism and should give some information about the clinical course, provide invaluable information on the prognosis or guiding in therapeutic decision, that means antibiotic stewardship. So as far as the ideal biomarker is concerned, for the sepsis or for infection, we still don't have any ideal biomarkers, although a plethora of the biomarkers have been studied, but none of them has come as close to the procalcitonin. So we know about the procalcitonin that it is in the health or in disease. In the health, it is produced from the medullary cells of the thyroid, and almost all of them they get converted to procalcitonin. So you don't get the normal. The normal level is less than 0.05 nanogram per ml. But in the disease state, this gene is stimulated by the lipopolysaccharide, toxins, inflammatory mediators like IL-6 and TNF-alpha, and they start producing procalcitonin from many organ system and eventually goes to the blood circulation. And this is the reason that's why in the bacterial infection, mainly the procalcitonin level is elevated. As far as indication for PCT-guided monitoring for the is concerned, the procalcitonin can be used for many indications in ICU, which is to confirm or exclude the diagnosis of sepsis and septic shock, including the differential diagnosis. Then we can also assess the severity of the systemic inflammation caused by the sepsis. We can follow for the systemic inflammation after focus removal or focus therapy to assess the efficacy of the treatment. And it can also be used for the proper antibiotic treatment in order to get the better estimate the duration of therapy or to withhold or stop the therapy. To determine the monitor patient who do not need antibiotic in the ICU, or to escalate the risk of sepsis and life-threatening systemic inflammation and bacterial infection. There are some other indications like in patient with pancreatitis for the early assessment of the severity and infection, to support exclude the diagnosis of bacterial infection with high or low probability like bacterial meningitis, bacteremia, peritonitis, etc. Or for the diagnosis of fungal infection or any other diagnosis may be present if no decrease in the PCT level. It can also be used for the outpatient monitoring for the treatment of respiratory infections. This is a recent study, so I've tried to include the studies which has been done recently. Done in 2016, it's called MOSES study, and they wanted to look as a prospective observational study that whether the procalcitonin decrease from day 1 to 4 is associated with decrease in mortality and not. So this study was conducted in ICU, and what they found that the procalcitonin level, decrease in the procalcitonin at the day 4 from 80% to the baseline is associated with increased survival. And this has been confirmed in both univariate and multivariate analysis that procalcitonin decrease from baseline to day 4 was one of the only factor which was associated with improved survival in these patients. And as you can see here, the decrease in the procalcitonin was associated with improvement in the survival. As far as the diagnosing pneumonia is concerned with the procalcitonin, if the initial level of the procalcitonin is very high and a suspicion of pneumonia is there, that means less than 0.5, the probability it is a viral origin. The 0.25 to 0.5 probability can be of atypical, or if it is more than 0.5, it can be of a bacterial origin. Risk of bacteremia, septicemia, and septic shock increases if the procalcitonin increases to more than 1 and goes above that. Procalcitonin for the diagnosis of pneumonia can help in differentiating CAP from other non-infectious causes. It can help in de-escalation of antibiotic and also help in severity assessment. Although the recent studies don't support the use of procalcitonin, as Dr. Gunjan has already mentioned about the PROACT trial, there's no difference in antibiotic-free days or survival or increase in C. difficile in procalcitonin group. So the recent Indian guidelines as well as the ATS guidelines, they do not we recommend that empirical antibiotic therapy should be initiated in adults with clinical suspected and radiographic confirmed CAP regardless of initial procalcitonin. So as far as starting antibiotics on the basis of procalcitonin level is concerned, the guidelines and the recent results of the trial, they clearly suggest that it's not very useful. This is a recent Cochrane meta-analysis which is done for the effectiveness and safety of procalcitonin evaluation for reducing the mortality in adult patient with sepsis, septic shock. And they also again found the same as for mortality at follow-up 28 days or ICU discharge is concerned. Procalcitonin guided algorithm did not help in decreasing the mortality, although most of the studies were of the high risk of bias. This was a study which was conducted recently again. They wanted to look for the outcome of with procalcitonin guided algorithm and the effect on mortality. So these were for healthcare associated pneumonia. And they have found that in this trial, they have seen that they compared the procalcitonin, CRP, WBC, the pneumonia severity index and curve 65. And apart from the clinical parameters like this PSI, of course, is a combination of the clinical as well as radiological. The PCT amongst CRP, PCT and WBC, the PCT had the best scoring as far as diagnosing or predicting outcome is concerned. So PCT was better as compared to CRP and WBC in this particular trial. Dr. Gunjan has already spoken about this trial, PRORATA trial. And we know that the PRORATA trial, again, it was conducted to look for whether the procalcitonin use associated with decrease in the antibiotic usage or not. And as far as outcome is concerned, of course, outcome, there was no difference between the procalcitonin group versus standard group. But of course, in the procalcitonin group, there was a decrease in the number of the antibiotic usage was significant. The mortality, the 60 days mortality, which was slightly higher in the procalcitonin targeted group, there was no difference, a statistical significant difference. So to check for that, again, new study, which was SAP study, was conducted. This was again a prospective multi-center randomized control trial, which was conducted in 15 hospitals in Netherlands, and they compared the procalcitonin guided group with the standard group. And in this particular trial, they clearly showed that the procalcitonin group, the antibiotic use is much lower compared to the standard group, and the mortality, although was different, or it reached a statistical significance. So this was an unexpected finding from this study. And the cost also, they did not total cumulative cost they have done, there was no difference, but the median cumulative cost of the antibiotic per patient was significantly lower in the procalcitonin group compared to the standard group. And this trial, as you know, that there is no difference in the mortality also between two groups, and there was no difference in the CRP level between the procalcitonin group and the standard group. So coming to the ideal biomarker again, so whether the ideal biomarker should be present at the symptom onset or even earlier to allow for early diagnosis. So do we have the evidence? Yes, we do have some evidence. It should be highly sensitive and specific for infection. We have some evidence for that. Being capable for identifying the causative microorganism, so procalcitonin cannot do that. It should give the information in the clinical course sometime. It may be, depending on the level, which is if this elevated too much, it can help in getting some prognosis. Yes, if the levels are too much, the prognosis is bad. This has been proven in many studies. And guiding the therapeutic decision as far as this is concerned, I think the biggest, strongest evidence is associated with procalcitonin on the antibiotic discontinuation. It has been seen in almost majority of the trial. Yes, the number of the antibiotic days reduced can vary between different trials, but the finding has been consistent in majority of the trials and meta-analysis. So in my view, the procalcitonin measurement can be used for diagnosis infection and sepsis, although the evidence is of low quality. Procalcitonin can be used as the severity of the infection. It has strong evidence. It can be used for starting antibiotic. The data is not very strong in that, and can be used for de-escalation of antibiotic and antibiotic stewardship, and the very strong evidence is there. Cost effectiveness, very few studies have been done on that, and I think we require more study to look for the cost effectiveness. Thank you very much. So Dr. Gunjan, you want to say something?
So thank you so much, Dr. Muzammil, and it was a wonderful presentation. And of course, almost negating all the points that I have said. But if you noticed, I mean, if the delegates or the audience must have noticed, most of the trials that Dr. Muzammil quoted were from 2016 to 2017. And the latest trials which are there are mainly from 2019, 2018, which is clearly say that the procalcitonin is not having a very important role. So the generic question actually remains how to prove that this test is useful or it is not useful. That is what is the final thing. And probably this applies to all the diagnostics in the field that in critical care that we have. So for example, it took us decades to realize that the routine use of pulmonary artery catheters in the ICU was actually unnecessary. So probably we will take decades to realize that procalcitonin usage also is probably unnecessary at many points. And if you go recently, see the B-type natriuretic peptide, which guided the treatment for change in congestive heart failure. It has also shown not to improve outcomes in hospitals with clinicians who have expertise in heart failure and who have robust usual care. So we should recognize that this story of procalcitonin is also not going to be unique, and probably it will follow the same story of PA catheters and the B-type BNP levels. So for critically ill ICU patients and sepsis, I believe that procalcitonin should not be used for antibiotic initiation decisions, but it could play a modest role in shortening antibiotic duration, because clinical suspicion is what is more important when you are suspecting infection. And of course, there are many flaws or loopholes in diagnosing sepsis. You can lead to overuse of antibiotics. However, if we talk of antibiotic stewardship, the increased attention if you give to antibiotic overuse and stewardship and evidence-based movement, if there is evidence-based movement in the hospital towards shorter antibiotic courses, this may itself limit the antibiotic use, and the incremental opportunity for procalcitonin will thus be limited. In fact, if you see the most current meta-analysis have only found a reduction of 1 to 1.5 antibiotic days reduction with the use of PCT guidance in the ICU. Whereas I agree that any reduction is laudable and the impact of 1 to 1.5 reduction on, but the impact that has been seen of this reduction of 1 to 1.5 days is actually does not reach to any change in the antibiotic resistance, and whether it does, actually that fact is still unclear. So it is possible that procalcitonin guidance combined with a robust antibiotic stewardship program may have a greater impact. However, if you actually see just an antibiotic stewardship program alone might be sufficient in reducing the antibiotic use. It is also possible that procalcitonin guidance in hospitals with more liberal use of antibiotics for LRTI may have a greater impact when you use procalcitonin. However, the simple intervention such as basic education may also prove to be impactful in these settings. So at an individual clinician level, I urge to all of you all to take thoughtful consideration to when to order tests and how to use their results. And also I insist that should you choose to order procalcitonin, it should be ordered in cases of clinical uncertainty, so as to have the greatest change in changing your management. And also you should be prepared to follow the procalcitonin guidance. I mean, the recommendation that is there, that if there is fall, you should have the courage to stop the antibiotics if the procalcitonin drops to more than 80% of the peak levels. And above all, we should continue to use all traditional means of diagnosing and assessment, with procalcitonin being only one part of our decision making. Thank you so much.
Okay. Thank you, Dr. Gunjan, for all nice thoughts. So with this, we are going to end our presentation. Thank you.
Thank you.
Thank you, Dr. Gunjan and Dr. Mozamil, with such an interesting pro and con session. And of course, it served the purpose. A last word about Dr. Gunjan is already said. Procalcitonin is actually whosoever is requesting for the test should know the actual scenario, as well as what are the circumstances and how to use their results. Similarly, like weapons are important to win any war, but definitely strategy is also very much important. It's not just the weapons which actually lead to the combat of the war. You have to have a simultaneously good strategy. And similarly, the procalcitonin can restrict the antibiotic under the antibiotic stewardship, but sometimes it has the potential to increase the use of antibiotics. And with this, we conclude this session. And now the valedictory session will start at 12:30. Thank you.
Code blue 508. Code blue 508. Code blue 508.
कार्डियक अरेस्ट हुआ है, हम कोशिश कर रहे हैं। एक्सक्यूज मी प्लीज, ये कौन है? ये आईसीयू के डॉक्टर है।
रवि, ब्रेकफास्ट रेडी है।
वाह माँ, बहुत ही बढ़िया बना है, थैंक यू।
ये रिश्तों की दूरी कब तक रहेगी बेटा?
पता नहीं पापा, कुछ कह नहीं सकते।
पापा मत जाओ ना, कभी तो मेरे साथ रुको। आपके बिना ही मैं बड़ी हो रही हूँ। जाने दो ना।
आप जाइए, मैं संभाल लूंगी।
मैं कभी डॉक्टर नहीं बनूंगी। आई हेट डॉक्टर।
सर ये अनुज डॉक्टर भी पॉजिटिव है क्या?
हाँ
सर ये अनुज डॉक्टर भी पॉजिटिव है क्या?
हाँ ब्रदर, अनुज भी पॉजिटिव है।
तो आप अकेले क्या आज ड्यूटी पर?
अरे अकेला कहाँ, तुम लोग जो हो साथ में। लेकिन
यस सर।
सबसे पहले मास्क पहना जाता है,
यस सर।
बाद में किट। मास्क पहनो।
जब तक पेशेंट
ठीक
एक्सपायर
है।
नहीं होता ना, तब तक वेटिंग पेशेंट को आईसीयू में बेड नहीं मिलता है।
मैं भी डॉक्टर नहीं बनूंगा, मैं कमांडो बनूंगा। कल रात को आप कौन सी फिल्म देखते सो गए? लेकिन ये फाइनल वाला है। क्यों क्यों क्यों? कमांडो भी फौजी होते हैं लेकिन अलग। जैसे? अलग लेवल के हार्डकोर फाइटर्स, अलग लेवल का प्रेशर गेम और फुल एड्रेनलिन। रवि के काम में एड्रेनलिन नहीं होता? मैं आपकी तकलीफ समझता हूँ, बट मेरी प्रायोरिटी मेरे पेशेंट की लाइफ है।
कॉर्पोरेटर का एक फोन आएगा ना, बराबर समझ में आएगा प्रायोरिटी क्या होती है।
धमकाना, ब्लेम करना, मारपीट करना आपकी प्रायोरिटी हो सकती है, मेरी प्रायोरिटी मेरे पेशेंट की लाइफ ही रहेगी।
थैंक यू डॉक्टर, बट हु आर यू एग्जैक्टली?
आई एम इंटेंसिविस्ट इन चार्ज ऑफ आईसीयू।
मतलब?
क्रिटिकली इल पेशेंट्स जिन्हें वेंटिलेटर या ब्लड प्रेशर सपोर्ट मेडिकेशंस की जरूरत होती है, उन्हें ट्रीट करने वाले स्पेशलिस्ट डॉक्टर इंटेंसिविस्ट होते हैं। हम हर एक पेशेंट को अपने फैमिली मेंबर्स की तरह ट्रीट करते हैं।
आपको आपके पापा पे प्राउड फील होना चाहिए बेटा। वो घर पे टाइम नहीं दे पाते क्योंकि वो लोगों की जान बचाते हैं।
क्या मेरे पापा कमांडो है?
इंटेंसिव केयर के डॉक्टर मतलब मेडिकल फील्ड के कमांडो ही होते हैं।
फिजिकली, इमोशनली और नॉलेज वाइज भी इट्स अ टफ जॉब।
दैट्स व्हाई इट इज कॉल्ड क्रिटिकल केयर यूनिट। और एक पेशेंट। One more life to save. Let's move. We are at war against COVID. Indian Society of Critical Care Medicine, ISCCM, founded on 9th October 1993, is the largest non-profit association of physicians, nurses, physiotherapists, and other allied healthcare professionals involved in the care of critically ill. It is actively involved in improving the standards of care of critically ill patients in India via education, training, and research. It now comprises of 88 branches with more than 13,000 members, and all are actively fighting this battle against COVID-19.
Sir. Sir, free papers. Sir, Govil sir. Govil sir.
Yes, please.
Free papers में आज का जो numbers आए हैं, they are the free papers which were valued yesterday and day before. उसी में the top 5 are coming. There is no difference in that list which is prepared yesterday. So I will ask Prajakta to project the results today, and the free papers, posters, and the ISCCM Day Best Poster Awards also will be announced today.
If we can request Dr. Subhal Dikshit, who is the chairman of abstract committee, to announce the names of the free paper and poster, it will be great.
Yes, sir. As the Excel sheet is projected, he will announce.
He will. Okay.
Good afternoon, sir. ध्रुव ज्वाइन हो गया?
अभी होंगे सर 2-3 मिनट.
अच्छा, हाँ, ध्रुव is joined. मैं 2 मिनट में ज्वाइन कर रहा हूँ. Srinivas and Govil sir, for the posters. Hello. Yeah, for the poster, Srinivas has just sent you the results for the posters. दीप्ति मला का 20 का 3 अलग दिया है और ISCCM का 5 पोस्टर्स के लिए अलग दिया है. So total there are 8 posters and 5 papers.
मुझे नहीं, श्रीनिवास को.
उनको भी कर दिया सर. उनके पास में मैंने. Sir, there are posters, 8 posters, na sir? You are on mute, Dr. Subhan. You are muted, Dr. Subhan.
Yeah, I'll just, I got it.
Sir, मैं PPT पण बनवली आहे, मी PPT बनवते.
Okay. Yeah, Srinivas.
Yes, sir.
I've just sent you the names of the posters winners as well as you and Govil sir on WhatsApp.
Yes, sir.
Poster and for the on the
sir, isme, sir, just for my clarification, Namita Ravi Kumar and Ayush Goyal are first prize.
Yes.
Dinesh Buntla and Shreyas Gutte are second prize. And Neeraj Kumar is third prize. That's all.
1, 2, 3, 4, 5. These are 1, 2, 3, 4, 5. 5. All are going to get 5,000 rupees each.
Okay.
You can just say that one of the best posters. There is no first, second, and third prize as such.
No, for free paper, sir.
Free papers, first, second, third. 1, 2, 3. These are Namita, Ayush, and Dinesh. 1, 2, 3.
5 है ना सर उसमें?
हाँ 5 है. तो अपन 5 papers को देते हैं ना sir. 5 papers we give the prize. 5,000 rupees each, out of which you can say first, second, and third is Namita, Ayush, and Dinesh. Fourth and fifth is Neeraj. And for the posters, Dipti Mala wanted to be given as not along with ICCM. So 11, 5, and 4 Dipti Mala. Okay, we are live. So that is there. So that posters ka have written the distribution.
But and you announce this, sir. I will ask you. I will invite you on this, sir.
Okay, I'll announce.
Yes.
Good afternoon.
Good afternoon.
Deepak, you are muted.
Can we start now?
Please.
Dr. Srinivas, please start.
Okay. Good afternoon, ladies and gentlemen, and dear friends and members of the Indian Society of Critical Care Medicine. Thank you all for joining us for this valedictory function of the virtual Critic Care 2021. It's been a fantastic effort, and it's been a entertaining and educating experience in holding this 5-day extravaganza for the Critic Care 2021. We are here to acknowledge and thank all of you and to declare the results of the posters and the free papers which were displayed and presented during the Congress. May I now request the President, Dr. Dhruv Chaudhary, sir, to address the gathering and deliver his vote of thanks. Sir.
Thank you, Dr. Deepak Govil, Srinivas, Subhal, Dr. Pandey, and the new and the outgoing members of the EC. I think it has been an interesting experience and a very valuable experience over last 1 year. And from starting with an optimistic note from Hyderabad, then going through whole of it, the year, I think everybody had been busy, but still the business went on. Physically, we were not able to meet, but I was fortunate enough yesterday to go to Gurugram. And I'm really happy that I could pass on the baton to Dr. Deepak Govil in physical form. So I think that was really satisfying. And thank you, Deepak, bearing with me. Sometimes I have been little this thing, I have been too demanding from it. And trust me, it is easier to say, ki aap kar lo, nikal jao. But nevertheless, I think every person of the society has contributed at every place where they have been. And I think this year has shown the relevance of those professionals in critical care. And probably I'm certain the youngsters who always have been asking a question, sir, nobody looks at the intensivist, we look like a second fiddle. I think they have realized now. I used to tell them, as your day will come. I remember discussions with a lot of youngsters. Your day has come, you have arrived. The only thing is that now that is the first part, the relatively easier part. Now will be to continue to show your relevance in the context of your institutions, your cities, your states, and you should not simply sit down. And I know all of you are extremely focused, extremely hardworking, and also want to excel, that everybody is there. But my advice to all the youngsters will be, learn to do a work-life balance. I think that will be very important. And along with it, when we say work-life balance, prioritize the things, but at the same time, try to get involved more and more with the community service and health. With my 30, 40 years of experience now, 81 I joined the MBBS, the medical profession. So now with the nearly 40 years of experience, I can say it will be worthwhile, because remember one thing, the power of medical profession is power to practice. If you look after your patients, if you look after the well-being of your patients' families, trust me, we try to remember the best and the worst thing, but the large number of people who come and thank you very much from the bottom of their heart. I think that will be my parting advice to all of you. Be a good human being first, then a good professional, be truthful, and build trust. I think if you are able to do it, probably your job will be done. Look for the welfare of everybody. That's all I will say it. And Society of Critical Care, I'm so thankful to each one of you for giving us the opportunity, the time, and what I am today. A very important section of it has been contributed by the Society of Critical Care Medicine. And I would like this opportunity, if Deepak and Subhal permit me, to thank not all my past presidents. They have done an exceptional job because of which we are here. But I will definitely, from the bottom of my heart, yesterday I said it in a presidential address also, is I would like to thank a couple of people. It's not that I'm not honored by, or I'm not thankful to the other, but sometimes you see, this is the official platform. And first and foremost, I would like to thank Dr. Shirish Priyak. He has been an elder brother, father figure, and a nudging and a guiding force in the critical care. And I salute him for his foresight, vision, and the love and affection he has given to me, to my family. And he has been brutally honest and critical to us. And I think that has shaped us, helped us doing it. I think, thank you so much, sir. Without you, it would not have been possible, this journey. And secondly, another person I said yesterday also, Dr. Narendra Rungta. He has also accepted with all faults. And it's not that we discussed only medicine. We discussed a lot of politics. We discussed a lot of social sciences, and we had our own share of differences. Similarly, I had a great opportunity to work with Dr. Rajesh Chawla, Dr. R.K. Mani, Dr. Ramraj Gopal, Dr. Farhad Kapadia. All of them have been there. And nevertheless, I will be failing in my duty if I do not recall and remember Dr. Jiggy Devetia. Always gentle, very piercing, and always coming with something else. And Atul, I'm not seeing him, but Atul, thank you so much. And each one of you who has contributed to it. And last but not the least, most important of my friends, where I am today, we discussed everything threadbare, is Dr. Deepak Govind, the incumbent president. I think it has been there. And before that, probably it was Kapil and Subhal. Subhal in particular, I just want to see it when I stood for the post of secretary. It was he also making up his mind. I just simply requested him at Bob, first one. If you remember, Subhal.
Yeah.
And that is not a beginning of a professional relationship. I think that was the beginning and the bonding and the personal relationship. I think that is the spirit with which we all have come up. And that is whether it is me, whether it is Deepak, Subhal, Rajesh is there, I can see. So is all of you. So it's a part of my family now. So there is one part. So ISCCM, all of you are part of family. And what a revelation it has been. Srinivas, Gunjan, Bharat, everybody whom I can see. It's not all that are not there, but what I can see. And there, I think what is important is differences are going to be there. Differences of opinion are going to be there. But matbhed ko manbhed mein mat badalne dena, that is the key. That is very, very important, because difference of opinion is an essence for progress. I think that is very important. And when one puts a viewpoint that may be contrary to yours, but respect it. That is the beauty of it. And I will, parting word to Deepak will be, though he is a very wise man, is that the person who has to bear the most is the head of the family. And now as a head of the family, probably you will be inundated by very different thought processes, very this thing. But sometimes it's good to suffer in silence. And I know you know it, I'm just re-emphasizing it. Probably that's how the family stays together and we work together. And thank you each one of the participants who have been there, each one from the industry who has been there. And again, thank you very much for the love, affection, regard, which all of you are there. My thanks from my bottom of my heart, core of my heart, and my feeling of gratitude to each one of you. Thank you so much.
Thank you, Dhruv.
Thank you, sir. On behalf of the Indian Society of Critical Care Medicine, the Organizing Committee of Criticare 2021, and the Executive Committee of the 1920-21 term, it's my privilege and an honor for proposing this vote of thanks as the Organizing Secretary of the Congress. Before I sign off, I would like to reveal the statistics of this Congress, which tested our resolve, which tested our organizational ability, and which also tested our ability to work as a coordinated team. Intensive care, by the dint of its qualification itself, is a teamwork specialty, and we have proven it now with this Congress. The total number of people who attended the workshops is about 4,000. 3,938 people have attended the workshops. The total number of people who attended the Congress during the last 2 days, that is 26th and 27th, and today the 28th of February on the last day, is 6,732. Although it's a virtual conference, this number is encouraging for the society as an educational platform. The e-poster zone had unique visits of 1,789. The ISCCM zone, which is meant to disseminate information about the courses, the programs of the society, drew 425 visits, and our partner zone got 843 unique visits. The trade had footfalls of about 3,086 in the trade zone. The total hits on the platform in these 5 days have close to 7 lakh hits. That's about 1.4 lakhs per day, and that's a phenomenal effort. And I thank each one of you and the back-end team of meetings and more, and my office staff for making this feasible and making this what looked like a Himalayan task very easy to climb and accomplish. Thank you all for the same. I also thank all the executive committee members for sparing time on the days of the workshops and the Congress for helping us to coordinate the halls and helping us to run the programs in a very smooth and efficient manner. All the faculty who have spared time to record their videos and send it to us on time so that we could collate all of them and run this program very smoothly is what makes this conference so successful. No conference is successful without the delegates. And my thanks to each one of you for having come forward in this hour, at this moment when the conference was not physical, yet showing solidarity with Criticare and logging in great numbers and making this conference successful. On a personal level, I'm extremely indebted to Dr. Dhruv Chaudhary, Dr. Subhal Dikshit, and Dr. Deepak Govil, the 3 members of the office bearers team who have helped me, who have guided me, and who have probably counseled me when things were not going right on certain situations. Taking this counsel, taking the advice from such people has been a big learning experience for me, and I'm sure I'll be a better human being and I'll be a better person in future just because I had the opportunity of working with these 3 great administrators and clinicians, and of course senior members of the Indian Society, and I cannot express anything more in words before all of them. The industry has always supported us, and this year I'm very happy to say that we had good number of partners. We had our platinum partners, Ceylon, represented by Mr. Y.V. Srinivas, Pfizer, represented by Mr. Supriyo Mukherjee, our gold partners, Gufic, represented by Mr. Samrat Lord, Takeda, represented by Mr. Ashish Gaur and Dr. Malvika Goyal, Sanofi, represented by Dr. Vijay Bhushanam and Mr. Shyam Shankar, Alnish Life Sciences, represented by Mr. Praveen Nayak, Cipla, represented by Mr. Satyasai Ishwar, and Cadila, represented by Mr. Amit Jain and Mr. Aditya Vikram. Our session partners, Converge Biotech, represented by Mr. Arun Bijala and Mr. Varun, Uric, represented by Dr. Vijay Chamle, Hansraj Nair, as always, represented by Mr. Chetan Nair, Concord, represented by Mr. Anup Dikshit and Mr. Jaini Shah. KEFID, represented by Mr. Varun Suneja. Striker, represented by Mr. Kuldeep Sharma and Mr. Pranit Singh. Alchem, represented by Mr. Sandeep Dey. Wokat, represented by Mr. Nitin Bhadana. And BD, represented by Mr. Anil Nafria and Mr. Virendra Patnaik. Our other partners, Edwards, represented by Mr. Gunjan Khurana and Mr. Vimal Soni. Bodytech, represented by Mr. A.L.N. Prasad. Teleflex, represented by Ms. Dhiksha Khanna and Mr. Rajnikant Chaturvedi. Sonosite, represented by Ms. Savita Alawat. And GE, represented by Ms. Rumela, have been extraordinary in their commitment, their promptness, and their forthcoming nature in supporting the Indian Society of Critical Care Medicine. All this virtual activity would not have been made possible without the support of meetings and more. The platform has withstood the 1.4 lakhs hits we had every day. The near seamless transmission of the sessions, the changeover of the program, the clarity of the transmission have all been winning points of this conference and have won the hearts of the delegates who could not differentiate a virtual conference from a physical conference. And no amount of thanks is enough to for Mr. Zia and Mr. Girish and the rest of his team. Special mention of Shekhar Singh, who day and night has been accessible to us and has helped us in carrying out this smooth program. Also, Nilay from PSS has been instrumental in making our IT connectivity prompt and efficient, and my thanks to them. Last but not the least, our office staff. They have been our pillars of strength over the years, and they have proved it yet again. But when the going gets tough, our tough office staff will get going. And I'm extremely happy and privileged to have worked with all of them. And with the permission of the incumbent president and general secretary, I would like to recommend that Nilay, Ninad and Prajakta be given 3 days leave from tomorrow, and the rest of the office staff 1 day leave tomorrow if the incumbent office bearers are agreeable to it. It's a small gesture for relieving them from the extraordinary hours they have put in for making this conference feasible. I may have forgotten to thank a few people. It's just by coincidence, and it is not intentional. And I'm thankful to all of you for having supported me in my tenure as General Secretary. I now invite Dr. Subhal Dikshit, Chairman of our Abstracts and Poster Committee, to announce the names of the free paper winners and the poster winners of this competition. Sir.
Yeah, thank you, Srinivas. Thank you, Dhruv. And thank you, Dr. Deepak Govil. I request Prajakta to please start sharing the PowerPoint presentation to declare the names of the winners. For the best poster awards, Prajakta, start from the first slide, please. Yeah, the oral and the poster awards, all the papers and the posters first time were invited, and all the posters were submitted into the online portal submission. They were analyzed and they were scrutinized by a panel of judges. And I would be very happy to declare the results for the oral as well as the poster papers for Criticare 2021. Next slide, Raja. For Namita Kumar, this is from PGI Chandigarh. She wins a cash prize of 5,000 rupees. Next is Ayush Goel from AIMS Delhi, a prize of rupees 5,000. Dinesh Pontla, the prize of rupees 5,000. Virinchi Hospitals from Hyderabad. And Shreyas Kute, Department of Critical Care, HCPGI Lucknow, a cash prize of 5,000. And Neeraj Kumar, AIMS Patna, Bihar, and cash prize of 5,000. Now for the best poster awards, we have got 8 awards. The first awards, I would like to thank Diptimala Agarwal and her family, and she's always supported. These awards are presented by her family in the memory of her mother. So first prize goes to Dr. Pooja Yadav. She wins a check of rupees 11,000 rupees. She's from CTB Hospital in Delhi. Second prize is Dr. Vijay Patidar, Sri Aurobindo Medical College Postgraduate Institute in Indore, prize of check of rupees 5,000. The third prize goes to C. Jayadevi. She's from the Government Medical College Hospital in Tamil Nadu, and she gets a check of rupees 4,000 rupees. The Best Poster Awards by ISCCM. The first prize goes to Dr. Ashish Suneja from Hiranandani Hospital in Mumbai, Powai. Next is Dr. Nishant Agarwal from the Bharati Vidyapeeth Medical College and Hospital. Third is Dr. Ashima Mishra from Burla. Fourth is Kayanush Kadapatti from Jahangir Hospital. And the last one is Dr. Shivangi Himalayan from the Institute of Medical Sciences. The ISCCM Best Poster Awards. First prize goes to Dr. Pratibha Tol from the BRC Hospital in Mumbai. Second prize goes to, and the consolation prizes are to Dr. Nishant Agarwal from the Bharati Vidyapeeth Medical College. Second is Dr. Megha Bhatt from Bangalore and Dr. Hemant Sant from the Sant Hospital, GPO, Vadodara. Next slide. Yeah, thank you. All the winners are requested to kindly contact the conference coordinator in the ISCCM office, and then ISCCM will be issuing a check in their name. You are kindly requested to submit your bank account details and PAN card to the ISCCM office conference coordinator for completion of the formalities. I again thank all the abstract judges, and I again thank all the delegates who have submitted their posters as well as abstracts. And this is for the second year, again, thanks to Dr. Dhruv Chaudhary, we have now come out with the abstract edition, which is being published with DOIs from JP Publications and IGCCM, and it will continue to occur. Thank you all, and thank you for giving the opportunity to look after the abstracts this year. Dr. Dhruv Chaudhary, Dr. Deepak Govil, and Dr. Srinivas Samavedan. And again, thank all the members of the executive committee, and thank you very much.
Thank you, Dr. Subhal, and congratulations to all the winners, and it's been a good experience. Before I invite Dr. Govil to make his comments, it is a small announcement. The certificates will be available for download from the industry zone soon after the conclusion of this valedictory program. So please don't leave the program and start searching for a certificate. Please wait till the valedictory is over. Only then the certificate will be available for download. It's my privilege and honor and pleasure to invite the incumbent president, Dr. Deepak Govil, to kindly address the gathering and the members online and give his message. Sir.
Thank you, Dr. Srinivas. First of all, I would like to thank all the team members to make this event successful. I would like to start with these words, which Dhruv has already said, but I would like to summarize with these words that power is an illusion, authority is a delusion, responsibility is a reality. So I request all the new incumbent team of EC and College Board to take these words and work on these words. Slide. So I would like to just, don't want to take much time. I would like to just tell you about these members who are completing the term. Dr. Dhruv Chaudhary, he is completing the term in this EC and will be becoming as a past president. I would like to thank him. I have already felicitated him yesterday in the physically when he was there, but I would like to say a few words about him again. He is a great visionary, and it was his vision which I try to follow in this 1 year as a president-elect, and I try to fulfill whatever he was thinking and his vision was. And I know we had sometime difference of opinion, and sometime I prevailed, sometime he prevailed, but it was like a unique experience working with him. Dr. Subhal Dikshit, I started working with him for many years back when we were in the college together, and I learned a lot from him. He is a great statesman, and he's a person whom I can fall back, and I used to fall back for any advice, anything, wherever there is a doubt, he was always there as a guiding light. Dr. Rahul Pandit, again, a good friend. He is leaving the EC. He was working as vice president, and now he's leaving the EC. Dr. Srinivas Samavedam, I found in him a younger brother. He was always there whenever I used to call him, and many times I shared my frustration with him. He was always there to give me shoulder. Dr. Sheena Nanan Mitra, she was vice chancellor in the system, but many times I prevailed upon her. I pushed her to a certain extent, and she always complied whatever the wishes were there. I would really like to thank her from my heart of hearts. Dr. Khushrao Bajan is also leaving the EC. We have abolished the post of secretary, so he will not there with us, but he was always there whenever the need be. Dr. Bharat Jigyasi will be joining back again as a treasurer. Dr. Seelpush Bhosle, who was the treasurer, again he's leaving the EC. I would like to place my thanks for him also. Dr. Gunjan Chanchalani, she is again joining as a zonal representative. Dr. Sunil Kumar again joining as a zonal representative. Dr. Suresh Ramsubban and Dr. Raymond Savio, we will be missing them in the EC. So I would like to place my thanks to Dr. Dhruv Chaudhary again, Dr. Dikshit again, and I know I can fall back on these two people anytime. Dr. Srinivas, he will be joining us as a vice president of the society. Dr. Sheila is, I would like to thank her. She'll be leaving us in the college board. So the new members who are joining, Dr. Chaudhary will be joining as immediate past president. Dr. Rajesh Mishra, who is a young dynamic person, and I know it will be very difficult to keep pace with him because he is a very fast mover. He and Dr. Arindam both are very fast mover. So I know at my age, it will be a little difficult to keep pace with these two, but I'll try to keep pace with these two, and I'll try to rather push them to a even faster speed. Dr. Srinivas Samvedam is joining as vice president, and I'm sure his rich experience of organizing secretary will help us immensely in the next conference. Dr. Rajesh Pandey, a very senior and a seasoned person, he is joining as a general secretary elect, and I'm sure his rich experience will enrich the society as well. Dr. Shrikant Srinivasan, one of my close friend, colleague, we worked together for many years, will be joining us as a joint secretary, and I am sure his skills as a joint secretary will help me in conducting day-to-day work of the society. Dr. Bharat Jigyasi is again joining back as a treasurer. Dr. Sunil is already there. This young guy, Dr. Hassan Ahmed, is again joining from the East Zone, and I am sure he will bring the new thoughts and the new ideas to the society. Dr. Mahan Maharaj, a very senior and seasoned person, he'll be joining from the South Zone, and I'm sure his wisdom will give us new light. Dr. Gunjan is joining back as a West Zone, and Dr. Pradeep Bhattacharya will be joining as a Vice Chancellor of the Indian College of the Critical Care Medicine, and I'm sure with his rich experience in the teaching institute, the college will get enriched. So welcome Dr. Mishra, welcome Dr. Arindam, welcome Dr. Shrikant Srinivasan, welcome Dr. Pradeep Kumar Bhattacharya. This platform will be live till 2nd March 2021 for downloads and the certificate, downloads of the certificate. You can even view the lectures of the conference till this date. I request the team of Ahmedabad, if they are there, to join us. Can you pin anybody there? Dr. Manoj Singh is there, as I have seen. Dr. Manoj Singh, are you there?
Yes, sir. Good afternoon, sir. I'm here.
Yeah.
Manoj, good afternoon.
Good afternoon, Dhruva, sir.
I think other people should be joining because link has been sent.
Yes, sir. Yes, sir.
Ritesh is there.
So I request all of you to join Ahmedabad Criticare in 2022, and we are sure that in Ahmedabad we'll be having a physical meeting. So it will be a 2 years gap to see each other and meet with each other. And I'm sure the Dr. Rajesh Mishra and Dr. Manoj Singh will put up an excellent scientific program. And with the skills of Dr. Arindam Kar, I'm sure it will be a great social evening in the Ahmedabad. So see you all at the Ahmedabad. Thank you very much, and over to Srinivas.
Thank you, sir. That brings us to the conclusion of this program. Again, to clarify for the office staff, with the permission of the incumbent president and general secretary, Ninad and Prajakta will get 3 days holidays, and the rest of the staff will get 1 day break tomorrow, and it is back onto the treadmill from the 2nd of March. So you have got a more tougher trainer today. So please be prepared, take rest today and tomorrow. Nourish yourself well for the tough task ahead. And I am extremely grateful for this opportunity. It's a once in a lifetime opportunity for somebody to be the general secretary of this extremely professional, dynamic, and highly intellectual society. And I thank God for giving me this opportunity. Thank you all very much. Have a safe time and thank you. Be safe. Thank you very much and bye bye.
Thank you.
Thank you, sir.
Bye bye. Thank you. Bye bye.
Thank you very much and stay safe because we are
Thank
seeing
you.
now again a resurgence of COVID everywhere.
Yeah.
So I would
Bye-bye.
just say stay safe and stay happy and healthy.
Thank you, sir.
Thank you.
Thank
Bye
you.
bye. Bye
Thank you.
bye.
Okay,
Thank you, Dr. Srinivas.
Thank
Thank
you.
you, everyone.
Thank you. Bye bye.
Bye and see you soon. See you
Bye.
soon at a better
Bye bye. Bye bye. Bye bye.
I am grateful to the entire Executive Committee of Indian Society of Critical Care Medicine 2021 and I applaud each and everyone who has contributed for having organized this conference on a virtual platform. I endeavor to keep up the momentum built by my predecessor Dr. Dhruv Chaudhary in strengthening Indian Society of Critical Care Medicine further, in organizing more conferences by creating a knowledge platform and more values to all our members. I invite you all to join us next year at Ahmedabad for 27th Annual Critical Care Congress with the theme being New Normal, New Frontiers, New Directions. Thank you very much.